please send them through on the app if you are not actually present in the building. And I'm going to hand over to our first chair of the morning, so Bernie Bissett. Thanks, Bernie.
Thank you, Hannah. So I'm Bernie Bissett and I am the Discipline Lead of Physiotherapy at University of Canberra, and it's my absolute pleasure to be chairing this session this morning, which is really focused on the research that's happening right here in our own backyard. So we have a mix of different speakers from different areas. Our first speaker this morning actually has 20 minutes because this year, great idea from the organising committee to have a bit of extra time allocated to those who have spent quite a few years chipping away at a PhD and really can't, it's very hard to do that in 8 minutes and do it justice. So we are delighted to invite Ben Cooper down to open this morning's session. And Ben is doing his PhD through the University of Sydney, and you also may recognise him from being part of our medical radiation team here at Canberra Hospital. And Ben's topic this morning is better targeting for moving tumours in radiation therapy. Can we please welcome Ben?
Just on here.
Yep.
Okay. Okay. Is it on? Yes? Okay. Good morning. My name's Ben Cooper, and I'm going to be talking today about better targeting for moving tumours in radiation therapy, which forms the talk which has been 8 years of my life doing a part-time PhD while working here at the Canberra Hospital for my paid job. So first, some acknowledgements. I'd like to acknowledge the Canberra Health Services to allow me to do this part-time PhD while I was also working. Of course, my supervisor, Professor Paul Keel at the University of Sydney, who put up with me for 8 years. And of course, this project, although I'm the face of this project today, it doesn't exist without collaboration and great help from your work colleagues and research colleagues. Okay. Lung cancer is one of the bad guys. So lung cancer is unfortunately one of the leading causes of cancer deaths. It's a difficult disease to treat. There are you have about a 17% chance of getting to a 5-year survival. So it's a bad thing to have. So, but helps at hand, radiation therapy. It's the good guy. So we can use radiation to carefully control these X-rays to help us see the tumour and also to treat the tumour. So this is what my project's setting the scene for where my project helps these lung cancer patients. All right, so a bit of an overview of the talk. First of all, I'll talk about why radiation therapy is a force for good, why we need pre-treatment imaging for our lung cancer patients. This is actually a critical thing, which you'll see. I'll go into a little bit of how radiation therapy works from the patient's perspective. And then I'll get into how we need advanced imaging techniques, particularly for lung cancer. And then I'll finally get around to where my research fits into all of this and how it can benefit lung cancer patients. Okay, so why radiation therapy is a force for good? X-rays are lethal, okay? But this lethal force we can use, we can guide them and direct them towards the tumour. So the challenge then is to ensure that we are getting all of that lethal X-ray dose concentrated where we want it on the tumour, whilst minimising any radiation to the healthy tissue. We've also got the added bonus that tumour DNA is much, much more susceptible to radiation damage than normal cells. Okay, so we can exploit this. Here's a little graphic of how X-rays can work. You can see here our big bolt of yellow lightning is actually an incoming high energy X-ray from the radiation therapy, and it directly damages cell DNA. So this is a balancing act because although it does harm the tumours more, it also will do this for normal tissue. So the real challenge is to absolutely concentrate those X-rays onto the tumour. Okay, so this is kind of leads into the next section about why we have to have pre-treatment imaging. All right, so what's that all about? Let's have a look. This is what a radiation therapy machine looks like. Now let's see if we've got a laser here. Is that a laser? Yes, okay. So here's our patient lying on the table. This big blue machine here is where the X-ray energy comes out. So in fact, if I click a few things here, the first thing I wanted to talk about though is this unit up the top. That's just a standard X-ray imager unit. So there's no treatment X-rays coming out of here. It's just X-rays to take pictures. Now, why is this important? Well, the patient comes in every day for about 5 weeks, okay, to receive their radiation therapy once they're onto the course of treatment. But we have to make absolutely sure that the patient is in the exact same spot each day. So to help us do that, we take these X-ray images to ensure that the anatomy is in the right spot. When we can do it by skin, that'll get you so far. But you really have to get that accurate positioning with X-rays. Okay, so that's represented by my green arrow. Okay, this yellow arrow, that's the big bad cousin of the, well, not bad cousin, the good cousin of the green X-rays, okay, because these are high energy treatment X-rays, much more intense, much higher energy. These are the guys that we use to kill the tumour cells, all right. So the whole thing then orbits about the patient according to a very predetermined, customised radiation treatment plan. Okay, next slide. So here, a little bit more detail about how this pre-treatment imaging works, and a thing called cone beam computed tomography. So we're starting to get into the imaging that's involved in my project work. So we've got that X-ray source at the top. This is just a kilovoltage X-ray, so they're low energy X-rays, comparatively speaking. Got the detector panel at the bottom, and this thing in the middle is actually a representation of a cross-section of a patient's chest. So you've got lungs there, but we're just seeing one slice through the lung, the level of where the lungs are. So the kilovoltage X-ray source orbits around the patient like so. Okay, and then we gather a whole bunch of X-ray pictures, or projections is the formal term. We pass all of those projections into the reconstruction computer here, and a whole lot of computing goes on, and then we can actually get a three-dimensional CT data set of the patient. So we've got this three-dimensional model of the patient as they're lying there on the couch about to receive their treatment. So this is exquisitely good information because we can then compare that to the plan that's been created for this patient and check that it's spot on. So if there is any little kind of change that's required, the whole point of doing this is to see, is the patient in the right spot? If they're not, we can actually use the information about how different they are to then reposition the patient. And then we might have to take an additional cone beam CT to check that the patient did indeed get into the right spot. So we're doing all of this and we haven't even started the treatment yet. But the reason is that we've got to get those lethal X-rays to the tumour. We've got to make sure that we're hitting the right spot every time. Okay, so this little video, this is now the big brother X-rays. This is the treatment beam. On the bottom right-hand corner, we can see the machine orbiting around the patient lying on the bed. This is what the tumour view is from here. So the beam's coming down and it's shooting from all the directions. And where the radiation overlaps in the middle, like have in your mind's eye an asterisk, where all the lines cross over in the middle, that's where the tumour has to be. And we've guaranteed that it's been there, that the tumour is located in the right spot, because we've done all of our pre-treatment imaging. All right, so we're sort of setting the scene here. How am I going for time? I'm sort of taking a bit longer because I know I can be a bit more expansive. I tried to cut it down and now we've got more time. Anyway, so I wanted to now talk a little bit about the particular requirements for lung cancer. Okay, we've got this problem of motion, okay? Lung cancer patients have to breathe. And this means that we're actually trying to hit a moving target. So we've got our Death Star tumour down there in the bottom lobe. So this presents a problem because all of our CT imaging so far gives you a static image, okay, one shot in time. So now what we actually require is actually kind of like a movie, a representation of how this tumour moves in time. So this is sort of where my work starts to come into the fold. But first I want to have a little bit more of what this actually looks like. So we're looking here at a coronal image. That's cutting down this way. This one's a sagittal image, like an arrow. It's cut you this way. And what we can do with this particular technique, we could just add the dimension of time, okay? So when we do that, I just have to click this one, we get a little movie. So we can see here the orange circles here, that's where the tumour's moving up and down. That's in the coronal view, the sagittal view. So we're now getting this time-resolved information about how the tumour is moving, again, just immediately before the patient's about to receive their treatment. So this is extra information that we need. Okay, so now I'm going to get on to what talk wouldn't be complete without a very complicated acronym. So 4D CBCT is what this imaging technique's called. What does that stand for? 4D, four-dimensional, so we've got the three-dimensional CT of the anatomy plus time, so that gives our fourth dimension. CB is for cone beam, that's the way the x-rays are projected, they're projected in a cone. CT is computed tomography, so that's the same technique that we use in a general CT, but you have many, many views that you put into a computer to get your three-dimensional model. But we add time here, so it's 4D cone beam CT. That's the imaging technique we use to get our little tumour movies. All right, so this slide, this is a bit more detail about how 4D cone beam CT works. This is conventional cone beam CT. So you can get this on our treatment machines already. This is sort of like the default how it would work. So I'll guide you through this slide because there's a lot going on. So first thing, we've got our blue line, which is represents the breathing motion and therefore the tumour motion as well, how it moves in time. So we've got time on the x-axis. We've got sort of two graphs here, the respiratory signal there, which is the blue line, and this little bar graph at the top, these represents the projections that are taken, all of those photographs taken, those x-ray photographs taken, as the machine orbits around the patient. So that's what this diagram here is on the right. It sort of represents the gantry coming around the patient, and I've just drawn, see where these red rectangles are? That corresponds to these three projections here for breath 1 and breath 2. I haven't drawn them all in because it would crowd the picture too much. So the critical thing here with 4D CBCT is that we actually add timestamps to our projections. So instead of just having projections there with 3D CT, we've actually got accurate timestamps on each one of these projections. Now this is critical because we know that in this time here, in this first little time slice, which we call bin 1, that's in this part of the breathing cycle, okay? So then we repeat it for bin 2. I haven't drawn bin 2. I mean, you can see the dotted lines for all the bins. And the whole point here is that we subdivide the breath. This is one breath from 0 to 4 seconds. We subdivide it into 10 time slices. And in each of those slices, we put a timestamp on the projections. So I've just shown you what it looks like for time slice 1 in breath 1 and time slice 1 in breath 2. And we feed all those projections with its timestamps, knowing where it is in the breathing cycle. And we feed it again to our reconstructor computer, and hey presto, we get our movie. So what we're actually seeing here at the top, each one of those frames corresponds to one time slice, bin 1 here, bin 1, bin 2, bin 3, bin up to 10 playing back. All right, so that's 4D cone beam CT conventionally. I just wanted to, before I leave this slide, draw your attention to the number of green columns here. All of those green columns represent one projection. You can see there's very, very, very many projections here. So even though these are the X-ray, the low energy X-rays, it's still X-ray dose. Okay, you'll see why this is important very soon. So my hypothesis is, this is sort of the central theme of the whole project. What if we limited those X-ray projections views to take just one projection per time slice per breath? Can we get away with it? And do we still have a useful movie loop? Can we still get our tumour motion from this? Why is this good? Because when we do this, we vastly reduce our imaging dose. So we saw all those green ones that we had before. Now we've just got one. This is sort of like the minimum requirement, is to have at least one projection in each one of these time slices. So this is the theory. We've got our tumour moving again. But this time, instead of having 3 projections in our time slice, we just allow one. Just one. I mean, there's 10 in a breath. I haven't shown all 10. I've just represented the first one of each breath. Do we still get, a question is, do we still get a useful movie loop? All right. And this is what we call, this is what I've coined the term respiratory triggered 4D cone beam CT, because instead of just running the projections at a constant rate, we actually do it in tune with the breathing. We monitor the breathing of the patient and take the projections as they breathe. Okay, so we're getting towards the end. This is sort of getting down to the pointy bit of my research. How does this benefit the patients? Okay, so here's our wise Yoda. We can get the same tumour movie. And I've got same with an asterisk, because you'll see why soon, but with fewer X-ray projections. Now this is really important because it means that you can get the same information for the patient, but with less X-ray dose. Okay, so this is a good thing. Even though you want the X-ray dose for the tumour to kill the tumour, you don't want lots of imaging X-ray dose for the patient. We want to try and minimise that. Okay, so that was all well and good on paper, but patients don't breathe sinusoidally. They breathe like this. These are actual patient recordings. Some of them look nice, some of them are a bit sort of fruity down here, and some of them are just, you know, these guys have lung cancers, right? They're not going to breathe regularly, generally, okay? So we've got to deal with this. This is where my work really takes the fold. Okay, so this is our plastic patient, because we don't experiment on live patients until you prove it in plastic first. What I did is I fed each 9 of those breathing traces into this machine. This plunger thing here moves up and down inside our plastic chest. These pink things here are the lungs. So that outlines we call this a thorax phantom for obvious reasons. And so I fed each one of those 9 patient traces into this phantom, and I did my respiratory triggered 4D experiments on it. To do that, I had to program a Raspberry Pi computer to monitor the patient's breathing and respond to that. So we had to respond in real time. If the patient slowed down, we slow down when we're taking our X-ray projections. So to realise that experiment, I had to do a fair bit of programming and interfacing with the medical equipment. So I had to get special permission to do that. Okay, and this is what it looks like. This is actually a movie loop of our projections being played back, one after the other, using the novel technique, the respiratory triggered 4D cone beam CT technique. In here is our Death Star tumour moving up and down. And you can see we're orbiting around our plastic thorax phantom. So this is the plunger moving up and down with the tumour in the middle. You couldn't see the tumour in the photograph, but you can see it on the X-rays, you see. So, you know, I love this movie because it took so long to make. Years, in fact. So when we feed, they're just the projections that we start with, but then we can turn it into our movie, okay, our CT movie here, which is what we've got here. So this is the coronal slice again. We're sort of cutting down here, and we can see our tumours moving up and down. So this is playing back a patient's tumour motion, okay, in our phantom, using the experimental technique that I've developed. Oh, yep, we've seen it. We need to go to the next slide. Okay, so we're nearly at the end. So this is what it looks like when we plot the position of that little tumour in each of the 9 traces. And what I've got a lot of information on this slide, which I'll take you through. What we've got here is the black line is the original source trace. That's the original breathing trace, okay? The blue line is the position from using my novel technique, the respiratory triggered technique. And then the dotted red line is the conventional one that uses all the extra projections. So the take-home message with this is that for these 9 patients here, I mean, there are some notable differences, but overall, we can get away with it. We can use far fewer projections and still get this information, this useful clinical information about how the tumour moves immediately before turning on the treatment beam. All right, so we're winding up now. So, this is my statement. This is sort of my final result here, is that respiratory triggered 4D cone beam CT requires half the projections. So half the X-ray dose on the average to get the same clinical information. This is a good deal for the patients because they're already receiving high energy X-rays to treat their tumour, but we're going to minimise the imaging dose that we're using to ensure that we're hitting the target. Okay, so final wrap up. So our Death Star tumour, we're using our radiation as a force for good, both the imaging kind and the tumour-sidal kind, to stay on target and try and get rid of this nasty tumour. All right, thanks very much.
Ben, thank you for a captivating talk. As a respiratory physio, I've never been so excited about lung CTs in my entire career. That was a great explanation, thank you. I'm sure we've got time for a couple of questions. We are going to run a little bit behind schedule just because we do have one speaker missing. Is Hannah? First question from you. Fabulous.
Absolutely fabulous, of course.
Thank you.
Great presentation, thank you. So my question is, given the time that it took you to program for the lung and the movement and all the other bits and bobs, how easy is this going to be for you to translate it to other moving tumours, such as things where you have the gut where that's constantly moving? I mean, how translatable is it to the others types of tumours?
Sure. Yeah, that's a good question. There are other approaches that are used for other sites. This particular technique is really only going to be useful for clinical sites that are affected by the diaphragm, essentially. So certainly lung. I've focused obviously on tumours in the lung, especially near the diaphragm, near the lower lobe. But it would also be useful, and in fact there is other research that's used it for liver motion, because if you've got liver cancers that are close to the diaphragm as well, exactly, it would help. But once you get further away, the effect of the breathing is not as great. But motion is still a problem because you can have all sorts of other movements going on. I mean, we're a sack of moving stuff, really. And so what another technology is used is where we insert these surgically. We insert little little GPS coils on, for example, a prostate. So prostate is affected by breathing a little bit, but not much. But other things, because it's right next to bladders and bowels, those can have a huge effect on the location. So for those cases, there are particular treatments that use these little GPS signals. There are 3 of them that are implanted, and they detect the motion of the prostate based on this GPS signal. It's passive, so they put out a radio pulse and see where it comes back, and they can locate in real time where the tumour is for that. There's a product called Calypso that does that. Yeah, we don't have any here in Canberra, but yeah, that's another technique you can use. So, but coming back to your question, this is really only for cancers near the diaphragm. Yeah.
One more question, Nick.
Hi, Nick Brown from University of Canberra Health Services. A technical question. So theoretically, you can sample at twice the frequency of the movement of the signal. So sampling theorem would say double the frequency and you'll get the full movement of the tumour. So breathing's what, half a hertz or something. So how infrequent can you sample?
How low can you go?
Yeah, how low can you go given the sampling theorem, for example?
Yeah. So so in this case, I've split the the one breathing cycle, or the average breathing cycle, because there is internal variation, into 10 time slices. You generally, you can't go much below about 6. Once you go lower than that, you could, that would be a further study to say, well, if I've used 10 bins, could we use even less? And further reduce dose. A colleague of mine actually looked at this, looking at the optimal time slice width as well. And they discovered that you could get down to something as low as about 20 projections per, so if you think about it the other way, if you limit it to 20 projections per time slice, then whatever bins that ends up being, that'll be n bins, that's the optimal. If once you get below 20, you lose completely. You just sort of get noise. You can't really detect anything. So does that answer your question?
Yeah, it does. Thank you.
Okay, good.
Thank you so much, Ben. I'm sure there'll be lots more questions, so please make sure you bail Ben up at another point in the Charm Week. Please join me in congratulating Ben on a fabulous work. Okay, next up I'd like to welcome Yuan Chai down for a presentation called Fast and Accurate Customised Pelvic Fixation Plate Design Using 3D Modelling and 3D Printing. So lots of exciting stuff about imaging this morning to get us going. Thanks very much, Yuan.
Hi, good morning, everyone. My name is Yuan Chai from Medical School of ANU. Today, my topic is fast and accurate customized pelvic fixation plate design using 3D modeling and 3D printing. So before I start, I'd like to acknowledge my supervisory panel, Dr. Rachel Lee, Professor Qinghua Qin, and Professor Paul Smith, and also thanks to all the grants supported this study. So this study was approved by the ANU Human Research Ethics Committee. First of all, I'd like to introduce you some background of my study. As you may know, that the mismatch between the standardized hip implant and the bone generate wear particles and eventually result in secondary surgery. So 3D printing can be a perfect solution as the geometry of the implant can be customizedly designed specifically for the patient. So it's supposed to have perfect match. The problem is that the customized implant usually designed referring to the uninjured side of hemipelvis. However, how fit it will be when we apply it onto the fracture side remains unknown. So the aim of this study is to investigate the geometrical asymmetry of hemipelvis and to design a customized implant referring to the fracture side of bone and compare the geometrical fitness of the implant. So this is how we did it. Firstly, we did symmetrical analysis of hemipelvis. We acquired the 2D CT image data from the patient and convert the 2D model to 3D in a software called DCMS. So we thresholded the data we need, which is the bone data, and mesh this region to get a very accurate 3D pelvis model. And when we get this triangulated 3D model, which is described by small triangles, we segmented the area of interest to get this, and then we mirror one side of the hemipelvis to be superimposed with the other side, and then we used a algorithm called registration, which is an iterative closed-set algorithm that helps the two model find its optimal position as a minimum deviations by comparing thousands of the small triangles distances. So after the registration, the two models look like this, and we did the deviation analysis here to generate the deviation color map, where the green color stands for the areas where the deviation lower than 1 millimeters, and the dark red and dark blue stands for the high deviation areas. So using this method, we did 13 cases here. So each case we generated, we used the front view and back view of the deviation color map. And for our further analysis, you may notice that when we segmented the area of interest. These three areas, pinked areas, were manually generated, which was not directly come from the patient. So we ignored these three pinked areas during our further analysis. So how we analyzed it, I will give you an example. This is the original deviation color map. So we further thresholded it to highlight the high deviation areas that are greater than 4 millimeters, where you can see the deviation color bar, where we thresholded at 4 millimeters, and the dark red and dark blue stands for the inward and outward deviation. So for example, case A here, we have a dark red at the pelvic crest region, which we record one case as a pelvic crest exhibited high deviation. However, like this area, which located the dark red and dark blue located in the pink region, so we ignored it. Similarly, case B, we have dark blue here, which we record as two cases now. At this region exhibited high deviation, and one more here. So using this method, we tallied all the 13 cases in this table and drew the deviation color map based on this table. So what does that mean? For example, the acetabular rim region, which we labeled A, you can find it here. For this region, A, we have 7 out of 13 cases exhibited high deviation at the same region, which is over 50%. Similarly, for the ischial tuberosity labeled B, which is here, have 4 out of 13 cases exhibited high deviations, which is the same with the area labeled C. So how can we use this result? We suppose if the fracture line go across the area that has a higher probability to be symmetrically different, it is not suggested to use the mirror on injured side of bone to design the personalized implant. So based on this result, we further designed a customized implant. So this is the case we used. You can see the fracture line directly go across the acetabular rim region. So what we did was we segmented each fractures, and we mirror the uninjured side of hemipelvis to be superimposed with the fracture side, and we use the registration function again to pull each fracture back to its optimal position, referring to the uninjured side of bone. So when each fracture holds its optimal position here, we restitched each fracture to be a full model, to merge as a full model. And then we designed the fixation plates based on this fracture merged model and did the deviation analysis between the plates and the pelvic model. So preoperatively, we can know the length and direction of each screw. And for the quantitative analysis, we summarize our data into this figure. You can see that the triangles is in general higher than the others in the deviation distances. So what are the triangles? Triangles are the front plate and the back plate compared to the mirror uninjured side of bone, which means that the plates we designed have better geometrical matchness when attached to the fracture side. So afterwards, we use 3D printing to print our model to get the unpolished and polished model in titanium alloy. So in conclusion, firstly, the geometrical asymmetry of 3D hemipelvis were analyzed and visualized in a color map where highlighted the areas had high probability to be symmetrically different. And 2, customized 3D implant design using fracture registration method had better geometrical fitness when attached to the fractured pelvis. So this is all my talk. Thank you.
Thank you very very much, you, and I'm sure we'll have time for at least one question from the floor. We've got a burning question. Yeah, there's a look.
Thank you. Lovely talk. Thank you very much. I'm just interested from a purely practical point of view, how long does it take to do all this analysis and then generate the 3D print? I'm just thinking about a patient coming into hospital with a broken hip. How long would he or she have to wait before she could have an operation?
Yeah, this is a good question. So when I got the CT data convert to 3D model, it's very fast, like 5 minutes. But the further processing takes much longer time. For example, if I need to pull each fracture back to its position and merge it and design the 3D implant, I think at least it takes half a day. And when we get the implant model and send it to 3D printing, I think at least 20 hours. So it's only an ideal time frame. And the ideal means that all the processing is perfect and the design has no problem in its geometrical. The 3D design is perfect in its mechanical properties, for example. But in reality, my supervisor told me that there was a case in the US which took half a year to get the final result. So you can see there's still a long way to go. So between the distance, what we need to do is to streamline all the design process and ideally let the computer do the design. So if we can achieve this final goal, I believe this will be much faster and hopefully we can get the final customized implants in less than a week.
Wonderful.
What
Thank you.
a fabulous idea. Thank you so much, Ewan, for a great presentation.
Thank you.
Isn't it exciting what stuff's happening in Canberra? I get excited every time I come to Sharm. Okay, so we've done the lungs, we've done the pelvis, we're going to get down to the knee now. I'd love to invite Diana Perriman to come and speak to us about the fact that shape is only a weak predictor of deep knee flexion kinematics in healthy and osteoarthritic knees. Now, Diana belongs to the Australian National University, but we over at UC like to think of her as one of ours too, so I'm going to say she's UC as well. Am I allowed to do that, Diana?
Yes, absolutely.
All right, thank you, Diana.
I probably might, yeah. Shall I just... Thank you. That's the other way, sorry. Sorry, everybody. Nearly there. Should I just hold it? Yeah. So I'm presenting this paper today on behalf of a larger team, and particularly Joe Lynch, whose PhD work this is. And spoiler alert, we give you the answer in the title. So knee osteoarthritis costs the society and the person who has it a lot. It's a big problem. It's not only for Australia, it's a big problem for the world. 21% of us over 45ers have arthritis, and many of it is knee arthritis. And that's cost Australia last year at least $1 billion, most of that in total knee replacements, because that's the definitive solution that we have now for severe osteoarthritis, and that figure is projected to rise astronomically. And so there's a huge push to reduce the amount of the surgical management and try and get our non-operative management up and going and much more effective than it is even now. Because 20% of people who go through this trauma of a total knee replacement don't feel better afterwards. So there's, as I say, there's a big emphasis on non-surgical options, and so understanding the osteoarthritic knee and its behaviour is crucial to optimising outcomes, and we've been working for many years, our big group, on this problem. Now, if you've got osteoarthritis, you've got a superpower. So I'm sure you've got plenty of superpowers, but one of them isn't bending your knee. And it most definitely isn't kneeling down. It's a big problem for people with osteoarthritis. Now, one thing we know about osteoarthritis, and this is Joe Lynch's PhD work, is that the bony changes in osteoarthritis are severe. You see that X-ray on the left? That is an osteoarthritic knee. Joe, as part of his PhD, has characterized the knee in 3 dimensions rather than this 2-dimensional projection, and actually had a look at where most of those changes happen using statistical shape modeling. And so he's found that the condyles of the femur spread out and expand. There's this little tubercle there that nobody has actually mentioned before. The tibial plateau expands out. The anterolateral condyles also expand. So you're getting all this expanding, this squashing out, and you're getting a squashing, a compression and flattening of the medial condyle and narrowing of that intercondylar notch. And very importantly, this squishing down and compression of the tibial plateaus. So that knee looks very different to a normal knee. So, unsurprisingly, we reckon that bony shape has got a lot to do with the fact that people can't kneel deeply. Fair enough. So what evidence do we have for it? Well, previous gait studies have shown that this is the case, that in fact shape is related to the kinematics, or the way the knee moves when you're walking in early flexion in stance phase. But what about kneeling? Does that altered shape we found in OA influence the kinematics of kneeling? Well, we hypothesize absolutely. Why wouldn't you? They're gross changes. So the aim of this study was to examine the association between that tibiofemoral joint shape and the way the knee moves, the kinematics, during deep flexion, so really coming down into this deep kneeling position. Okay? Thank you. In participants with and without osteoarthritis. So this is our group. We had 61 healthies, 58 OAs. They're about the same in age and sex. They were different in BMI. The OA group were much heavier. They had more pain, and they had less flexion, not surprisingly. To get all this data, we CT scanned all of them, and then we did a video X-ray or fluoroscopy while they kneeled up high on a box with their leg behind them, as I've shown you in this cartoon. And then we asked them to sit down deep and come back up again. And that took them from about 90 degrees of knee flexion to around about, well, the best one's about 140, 145, but more like 110, 120 for the OAs. Then we put all this complicated data together using OrthoViz, which is a program designed by Professor Mark Pickering, who's in the audience today, from the University of New South Wales, who is a collaborator on this project. And what this clever program does is it puts together the video fluoroscopy with the segmented CT scan by making a cartoon of this with lines at the edges enhanced, and we fit that to the fluoroscopy to create these models. And you can see that one on the left there, on your left, is a normal knee, beautiful, lots of range, lots of rotation, lots of translation, because knee movement takes more than just hinging. But if you have a look at this abnormal osteoarthritic knee, it doesn't go very far, and not much rotation, not much translation, it's really a bit of a hinge. So these models that are created, we visualized here, I've just given you an example of the data that comes out of OrthoViz, and lots of kinematic data in a curve form, as you can see here. Internal, external rotation, like that. Superior and inferior translations, a separation of the bones. Abduction, adduction, a tilting sideways. Anterior and posterior translation, the femur on the tibia. And median and lateral translation we didn't actually include in the models for this paper. So we reduced all this data, because there are thousands of points, reduced all this data down into principal components, which are basically the modes of variation. So it's reducing it so we can then use it. For these, the kinematic data created 3 bivariate principal components, as you can see here, with the first one containing all of those kinematic factors and explaining most of anterior posterior translation. The second one did again most of internal external rotation, etc. So then, to make those shape models I showed you before with all the colours on them, Joe fit a mesh to all the knees with nodal correspondence, put them all together to make Mr. Average Knee or Mrs. Average Knee, and then all the other knees were measured relative to that by these nodes. And so we had lots and lots of data, thousands of points. So once again, we made a principal component analysis and reduced them all down into modes of variation so we could use them in a model. And we made this model, this random forest regression model, to discriminate between OA and healthy, adjusted for BMI because it's an important factor, to work out whether shape was important in the kinematics of osteoarthritis. Does that make sense? Sorry, there's a lot of techie stuff I tried to reduce. So what do we find? Yay, we found that that shape does explain kinematics up to 50%. We were pretty excited about that until we looked at the error. And the error is so huge, we really wouldn't tolerate more than 10%. So this normalized root mean square error is far too high, which leads us to believe that bony shape is a weak predictor of kinematics, and we really were surprised by that, different to previous gait studies. But we know that OA does predict kinematics because Catherine Galvin's PhD work, Catherine's going to speak later, told us that that is the case. So we know our OA is a big predictor of kinematics. So what's going on? Well, we posit that it's soft tissues. In spite of all those horrible changes that we see on X-ray, we think maybe the soft tissues are much more important. In deep kneeling, remember this is deep kneeling, not walking, deep kneeling. So, so we know already that the meniscus is affected and deranged in osteoarthritis. We get scarring and thickening of the joint capsule due to this chronic synovitis. We know that BMI, people with OA are bigger. We know that they've got poor muscle control. In fact, strengthening is an extremely effective treatment for osteoarthritis. And if we actually look at this data through the lens of total knee replacement, an awful lot of time and energy and money is spent on the hard components of total knee replacement. But maybe we should be paying more attention to the soft tissues. Now, I'm not saying that the surgeons don't, because they do. Ligament bouncing is very important, and they're very careful about that. But maybe there's more to be seen than we know. And is that soft tissue the reason that 20% of people are not better after total knee replacement? So there were limitations. I'm not going to go through that. But in conclusion, if bone shape isn't as important, if those hard features aren't as important in OA knee, well, maybe they're more amenable to other ways of treating them than always opting for total knee replacement. So in future, we're looking at the moment on what different knee designs, hard components do to the knee kinematics. We'd like to look at modelling the soft tissues. Just telling you that now, Mark. And also, Jenny Scarville is certainly interested in evaluating the kinematically informed non-surgical strategies right in this very town. This is happening first, and you heard it first here. Thank you.
Very exciting stuff. Thank you, Diana. Any questions on the floor? So time for a question. Yeah, Hannah's on fire this morning.
She is.
Not on fire, but I'm quite happy to offer up my left knee if anybody wants it.
Okay.
Yeah, it's very interesting work, and I think there is a lot more work to be done in that soft tissue. So how do we get engaged in this? Because like I say, I have a left knee, I'd love to donate.
How do you get engaged? Well, Hannah, we've collected this big number of people now, and we're making the most of this data set because it's taken us sort of 10 years to achieve. But we are going to be doing more work. So I will be in touch with you, especially when we're looking at kinematically informed interventions in the future. So absolutely. And if anybody else would like to be involved, you're very welcome.
Any other questions for Diana? All right, thank you very much, Diana.
Thank you.
An onslaught of people with bad knees wanting to talk to you.
Thank you.
All right, thank you very much. I'd like to stay with the knee joint now. We're going to welcome Catherine Galvin to come down and continue the story. Now, Catherine wins a prize for the most difficult title for me to read out this morning. Prediction of the Kellgren-Lawrence knee osteoarthritis severity grade, a predictive data model using the kinematics of kneeling. And Catherine has quite a few different badges on, but again, University of Canberra, hooray, as well as University of New South Wales and Toru right here in Canberra. Thank you, Catherine.
That's all good. Thanks, Bernie. So, we've already heard a little bit about knees today. So in previous research, we have shown that knee osteoarthritis changes the kinematics or the motion at the knee joint. And so it prompted another question. Well, can we actually then use kinematics to predict osteoarthritis? Can we take it in the other direction? Firstly, before I go off this slide, I'd like to thank all my supervisors and colleagues that have helped me, quite a few of them in this room. It's been wonderful working with everybody. Diana's already done a wonderful job of why we need to actually understand and now predict knee osteoarthritis. As we know, we've just gone through, osteoarthritis is prevalent, and a lot of people getting it, more people are getting it every year. Other things, people who suffer from osteoarthritis, 1 in 6 have high to very high severe psychological distress from the disease. So it is a very important disease to study. What's very important to know at this point, there is no cure for osteoarthritis. So we are looking at other ways of dealing with the disease. At the moment, most people are diagnosed with osteoarthritis when it's late, when the disease is quite severe. Because it is actually almost impossible, well, it's impossible to diagnose osteoarthritis early with our current diagnostic tools. The problem with that, though, is if you can catch it early, you can make a difference to the knee joint. There are treatments now that help preserve the knee joint and maybe even long-term delay or prevent the need for a total knee replacement. So the early diagnosis is something that is really, really important, and that's what I was hoping to be able to develop a tool to make possible, or make it, the idea is possible. Now, other people have also said this is important, and there's an imperative now to find biomarkers that indicate osteoarthritis. But I'm going past that. I'm not just looking at whether or not someone has osteoarthritis. I wanted to know if it's possible to use knee kinematics to predict the severity. At the moment, research is covering 2 main groups. There's the wet group, which is terrifying, not used clinically, and the lovely structural or dry group. And they're the things that are, they're the people who are looking for biomarkers using X-rays, CT scanning, and what we're doing, knee motion. And it's shown great promise already. A paper came out in 2017 by Ms. Ghani, who used her structural biomarkers, which is actually knee kinematics during gait, and actually found that yes, knee kinematics could determine between healthy and OA knees, and so this was a great breakthrough. But what she didn't do in this paper, they didn't include healthy participants, asymptomatic participants, and they didn't grade them. They used motion analysis, so they got 60 knee kinematics from a specific motion analysis tool, but they had quite a small data set. But they did show in principle that it is possible. So what I did with our large, amazing data set, I used data mining and machine learning to see if I could find patterns in our knee kinematic data that would actually tell us perhaps there is a knee kinematic signature for each level of knee osteoarthritis severity. And I used data mining because it's a natural extension of statistical techniques. I wasn't relying on my central limit theorem. I didn't have to obey all the assumptions that I have done previously, and literally machine learning just looks for patterns, and that's what I wanted to know. I wanted to see if we could find some patterns. Finally, it also could develop a strong predictive model. So, using science, this was our aim. So we wanted to develop this predictive model. We wanted data mining, machine learning, using our knee kinematics and predict the Kellgren-Lawrence grade, which is how we can determine knee osteoarthritis severity. So we had 157 participants from 2 groups, healthy and knee osteoarthritis, and we recorded and quantified our knee kinematics using OrthoViz that we talked about earlier, and using a reference system called Gruden-Sunte. And I used, for my predictive modelling, I followed a standard called the cross-industry practice for data mining. Okay, so we determined the severity of osteoarthritis in our research, and we had a look at every single participant's knee. We did it slightly differently to the normal. We actually used a CT scan, and we had 2 groups of researchers that graded every single knee in our data set from 0 to 4. So from the earliest, from healthy to the most severe. So that was all done in-house. And then, as Diana has already beautifully described, we use OrthoViz to combine our CT and fluoroscopy scans to develop a lovely data set of knee kinematics. That's probably all I need to say about that now. So the data modelling. So this was wonderful fun. So we had this fantastic data set, and I had to work the data set. I've just got there what I did with the data. That's all following that standard system for data mining. You look at the data, you explore the data, you prepare it, you clean it. Is the data telling you what you think the data is telling you? And I finally ended up with 158 different kinematic variables that I could use in my modelling. I used SPS model, and I actually had tested over 200 different models, not just decision trees, but neural networks and a lot of different kinds of models. What I decided to do with my modelling was to break my data up into 3 sections, and this is standard as well. So you have a portion of your data you use that trains the model. That's what the modeler looks for. That's where it looks for its patterns. You then test it with another 20% of the data, and that keeps improving the model. And then there's 20% of your data that you keep outside of that routine entirely until it's complete. And then you bring it back in and see how successful the model is in predicting, in what we were looking for, osteoarthritis severity measured by the Kellgren-Lawrence grade. So we looked at our participants, and even though we start off with participants in 2 groups, healthy and severe OA, we actually did end up with participants across the Kellgren-Lawrence scale. But we had majority were healthy with a KL grade of 0 right up to the other end, and these were our pre-op osteoarthritis participants. We had 46 of those. So we were lucky to actually have a spread of KL or Kellgren-Lawrence grades in our data set. And here it is. This is the highest level model that I developed. And yes, it was very stable. That's one of the first tests. Is it stable? Does what the training, is it as successful in training as it is in validation? Yes, so it's a very stable model. And it was highly accurate. As you can see, it was almost 100%, and you never want modelling to be 100%. But I actually had to keep reducing the model and reducing the model and reducing the model so I could get it to 98% training. So very, very overall accuracy was very high. Now the most important predictors that have come out of this model to start with was the maximum flexion angle. Could they achieve 137 degrees flexion or not? And then at 130 degrees flexion, could they achieve that? Yes or no? And the other one was, could they achieve 90 degrees of flexion? Because people with knee osteoarthritis don't actually like to kneel with their body weight through their knee in that direction. Could they do that or not? And then the last one in my highest level model was how far forward was the femur relative to the tibia at a particular flexion angle. So they were my highest predictors of osteoarthritis. So that was, this is a bar chart of what we started. This is the actual data, the number of participants with each KL grade. This was our predicted data set. So as you can see, it was extremely accurate for KL 4, 3, 2, and I had 1 incorrectly graded. A healthy was graded at KL 1. So overall, the data was highly, highly accurate. And should I leave that up there for a minute so you'll see it? No. No. Very exciting. So it has now been done. We have shown that knee kinematics can predict knee osteoarthritis severity in kneeling, using kneeling knee kinematics. It's the first time a model has been built from both asymptomatic and symptomatic participants with their KL grades included. And what was really important about this is we can now, using this data, we can determine between healthy and early stage knee osteoarthritis. We've shown that in principle it is possible to do that using knee kinematics. We haven't designed this to be a diagnostic tool. It's really an idea in principle, but that has been very, very successful. We've shown that kneeling predictors are actually very different to those that came out in the GATE studies of Mezgani, which is also very interesting. But finally, following on from this, the next stage is really to develop these models into something that can be used in clinical practice, but we've shown that it is possible in principle. So I'd like to thank everybody I worked with, and there's some of my references, and there we go. Thank you.
Thank you, Catherine. You've got a knack for getting me excited about biomechanics again.
Yay!
All right, so
Of course.
time for one quick question from the floor.
Yes.
Right in the middle.
Hi, Jane Desborough from the ANU. So you said you didn't do this, you haven't done this in order to develop a diagnostic tool. Which
Not at this point.
Not at this point.
Not
So
at this
that's
point.
where I would see its value being.
Yes.
To improve access for people and understanding of their knee conditions. So MRIs, which are often the diagnostic tool of choice, are very expensive, and a lot of people can't access them until they can't walk properly. So there's a criteria for getting an MRI. So something like this is fantastic if people can actually be classified clinically and quite accurately in the first instance. So is that your intention?
I think that's a strong motivation. But yes, we do know that they're trying to reduce the amount of imaging that they're using for people with knee osteoarthritis. So the next thing is, so how can we proceed with this research and reduce the amount of imaging to turn it some kind of clinical tool?
Even actually improve diagnosis for people who can't afford the imaging.
Yeah.
So it's getting an access to diagnosis.
Yeah. So to me, it's opened up a whole new area where we can pursue that.
Thanks.
Thank you.
Fantastic. Thank you so much, Catherine. Please come and find Catherine during charm and ask some more questions. Thank you very much.
Yes. Thanks, Catherine.
All right, folks, I've got bad news and good news. And the bad news is that Jeff Louis is an apology for this morning, so unfortunately we won't have his presentation. But the good news is we're going to get to morning tea on time. So I know that's very important. So I'd now like to invite Deviation to come and join us for the next presentation. And Devashi's from the John Curtin School of Medical Research at the ANU, where she's doing her honours work at the moment. And her presentation this morning is entitled Investigating the Role of Mitochondrial Genomic Variation in Alzheimer's Disease. So back to the brain for something completely different.
Thank you, Bernie. Sound okay? People at the back? Yeah? Okay, cool. So first of all, thank you and good morning for coming here. Cold Canberra winter for making it to the morning session. Today I'll be talking about Alzheimer's disease. It is a progressive neurodegenerative condition which leads to memory loss and cognitive impairment, and it is the most common form of dementia. Currently it affects about 50 million people worldwide, and its prevalence is predicted to triple by 2050. How many people in the rooms know someone who is affected by Alzheimer's or dementia? Yeah, so Australia has one of the very high rates of dementia all over the world. And to make it worse, no drugs have been approved that cure, inhibit, or at least slow the progression of the disease. So this is the research that I'm currently pursuing with passion for my honours project. So I'm from the John Curtin School of Medical Research, and today I'll just be giving you a brief overview of my still work in progress honours project, which investigates the role of mitochondria in Alzheimer's disease. And these are very tiny organelles which produce ATP energy for smooth functioning of a gazillion biochemical processes in the body. Now, why mitochondria? Well, the most predominant model of Alzheimer's pathology is the amyloid cascade hypothesis, and it just suggests that amyloid plaques and tau tangles cause heavy neural damage, and this ultimately manifests into clinical symptoms. But based on this hypothesis, majority of the clinical trials have focused on these target mechanisms, and about 99.6% of the drugs tested till date have failed by phase 2 clinical trials. And this has invoked the scientific community to look beyond this classical model into other potential mechanisms, and this is where the mitochondrial cascade hypothesis comes in. And it just suggests that baseline mitochondrial function is determined by an individual's genetics, and it declines as it is further exposed to various environmental influences with aging, and the functional rate of change in mitochondrial function influences how quickly the damage occurs and spreads, and once it exceeds the threshold, it results in Alzheimer's-specific pathology. And several lines of evidence from epidemiological, observational, genetics, cell models, animal studies are emerging now to show support for this hypothesis. So for instance, Alzheimer's brains have disfigured, broken, and altered mitochondrial infrastructures like shown here, and they also show functional deficits in mitochondrial enzyme activity. So the dark bars are Alzheimer's as compared to the healthy brains. Furthermore, there's also evidence from cell models which suggests the co-localization and possible interactions between amyloid peptides and amyloid beta oligomers and also mitochondrial proteins. And it is speculated that these interactions could facilitate Alzheimer's pathology. There's also evidence from transgenic mouse models with mitochondrial dysfunction, which also show early signs of progression towards Alzheimer's disease. The most interesting line of evidence comes from hybrid studies. So here they prepare cell lines containing different mitochondrial DNA, for example, from the Alzheimer's subjects and the control subjects. And they're prepared on the same nuclear DNA background. And this is ideal because then we can control for the nuclear DNA variation and only look at the differences due to mitochondrial DNA. And Alzheimer's hybrids show distinct markers of mitochondrial dysfunction. So taken together, all this mounting evidence suggests that mitochondria might play a role in Alzheimer's pathology. But there remains much debate over whether mitochondria causes, mediates, represents a byproduct of the more fundamental events in its pathogenesis. And this is where my honors project hopes to contribute with two aims. So the first is to investigate the association of polygenic risk scores of nuclear encoded mitochondrial genes grouped by known biological pathways with Alzheimer's risk and endophenotypes. And the second aim will be to estimate the causal effect of gene expression of mitochondrial genes on Alzheimer's risk and endophenotypes. So elaborating on the first aim, one of the very complexities of studying Alzheimer's disease is that it is a polygenic disease, so it's driven by multiple variants contributing small effects. And most of the mitochondrial variants, which are shown here in red on the GWAS Manhattan plot, fall below the genome-wide significance level. And so they have limited predictive power when you look at any single variant. And that is why I'll be employing a statistical technique called polygenic risk profiling, which takes into account multiple variants from mitochondrial genes across the genome, and then it generates a single value estimate of an individual's genetic propensity towards Alzheimer's risk. And the effect size of each variant will be derived from large-scale GWAS summary statistics data. Here I'll take it from the International Genomics of Alzheimer's Project, or IGAP, and they have about 94,000 case and control subjects. And my research sample will be obtained from ADNI, Alzheimer's Disease Neuroimaging Initiative, which is about 1,500 subjects case and control data. To take a biological pathway and network-informed approach to interpret the GWAS effect sizes of these mitochondrial variants, I will be generating polygenic scores for various mitochondrial pathways for each individual from ADNI. And then I'll be doing regression analysis to see polygenic scores of which pathways show the most significant association with Alzheimer's risk and its endophenotypes. For example, CSF biomarkers like tau, beta amyloid, and also cognitive outcomes. For my second aim, I will employ a statistical technique called Mendelian randomization, and this will help tease out potential causal relationships between mitochondrial gene expression and Alzheimer's risk and endophenotypes. And the principle behind this is that in a conventional observational study, you measure your modifiable exposure in a group of people, for example here is LDL, and then you follow them up and relate the exposure to an outcome, for example AD, for example coronary artery disease, for example over here. But when examining this relationship, there are many confounders that may influence both the exposure and the outcome, and also reverse causation, which can confound the relationship when the disease process influences the exposure. So a much better method is to conduct a randomized control trial, which is considered the gold standard for inferring causal relationships, but then it has its own limitations like recruitment, ethical limitations, cost, time, etc. So Mendelian randomization is a powerful statistical tool which helps infer potentially causal relationships when large-scale randomized control studies are not possible, because it mimics similar principles to that. So in this example, similar to a randomized control trial of the random allocation of subjects into drug versus placebo groups, an individual's genotype is also randomly assigned during conception, and which then through an exposure, for example on the LDL plasma levels, it leads to an outcome of a coronary heart disease, depending on whether you have a risk or a neutral variant, similar to if you are assigned to a placebo or a drug group. Not only is Mendelian randomization more cost effective, it has also been shown to give very similar odds ratio estimates as randomized control trials. And a recent innovation in this field has been the integration of GWAS data about genotype and phenotype association and the expression quantitative loci or EQTL data. And this is all integrated into a Mendelian randomization framework, which allows us to estimate causal relationships between gene expression and the disease phenotype. I won't be going into the detail because then we'll be here all day. And I will employ this technique to look at brain tissue specific expression using data from GTEx and whole blood expression using data from EQTL-Gen. This brings me to the outcomes of this project, which will overall enhance our understanding of the role of mitochondria in Alzheimer's disease. AIM-1 will help us provide insights into what mitochondrial pathways may contribute to Alzheimer's risk, and AIM-2 will help us identify any potential causal effects of any mitochondrial gene expression on Alzheimer's risk, and which will later down the track help inform drug development strategies as well. And finally, I would like to thank a number of people who are taking this journey along with me. Thank you again for your presence here today.
Wow, my mind's just exploded. That's really exciting stuff. Has anybody got a question for Deviation? Yes, Diana.
Yes.
Because Alan Mackay-Sim this week in his keynote address on Tuesday commented that we've got lots and lots of cancer drugs, but where are the drugs for Alzheimer's?
Yeah.
You know, it's such a huge problem in our society.
True.
So I can only congratulate you and applaud you for taking on this really important challenge.
Thank you.
Thank you.
And I'm already hoping that we're going to see Deviation back again next year for the results at Charm 2020, right? Like, this is the biggest teaser ever.
I would love to.
Another question?
Yeah.
Thank you. A delightful talk, and poor mitochondria yet again blamed for everything. The thing that I think is interesting about this, and you may well be right, but one of the theories about the sort of progression and development of Alzheimer's is a sort of prion-like hypothesis that it starts in one place and gradually spreads to adjacent neurons.
Yes.
And I don't know whether you've thought about that, but I just wonder how something which might be nuclear affecting the mitochondria could tie in with that kind of evolution of the disease.
Okay, so so just to clarify the question, you're asking about how the mitochondria interacts with the nucleus and how, no?
No, I'm sorry if I'm
Okay.
making... and
Sorry.
I don't know if you know about this, but
Yes,
as Alzheimer's disease gets worse,
yes,
what seems to happen is that the cells which start out being affected influence their neighbours, and it's a
yes.
gradual spread of the
Right.
disease in a way that's similar to what happens with Creutzfeldt-Jakob or one of the transmissible spongiform encephalopathies, although the difference is that the transmissible spongiform encephalopathies are transmissible. You can infect, but you can't do that with Alzheimer's or Parkinson's
Right.
disease or one of those. And I'm just interested that if it is the mitochondria which are the problem,
yes,
how do we explain that gradual progression from one cell to the next?
right. That's a very, very interesting question, very insightful, I guess. Again, with Alzheimer's, the thing is there are lots of different hypotheses, and why we don't have a good drug is because we don't understand the causal mechanisms which are leading to that. And definitely, mitochondria is a multicellular organelle, so it's found all organelles. It's also multi-system in all the. So even Alzheimer's patients, we don't just see differences in their mitochondria in the brain, but also in other tissues like blood. And so again, it's a whole system problem, not just the brain. So I guess, that would be very interesting. But unfortunately, again, I don't have the answer to that.
No, of course
not the best
but
answer, but that's a very insightful, I guess, comment. Thank you.
I'm sure Deviation
Thank
will bring
you.
us lots more answers this time next year, I hope.
Hopefully.
Can you please join me in thanking Deviation?
Thank you.
And our lucky last presenter this morning, we have Dr. Kathleen O'Brien, who is from the ANU. And Kathleen will be speaking to us about a different kind of brain issue. So the risk of behavioural and mental health disorders and developmental delay in kindergarten boys and girls. Thank you, Kathleen.
Thank you. And I just use this. Yeah, it's not. Hi, good morning, everyone. Yeah, a bit of a change of pace. I'm going to talk about the risk of behavioural and mental health disorders and developmental delay in kindergarten boys and girls. And for the benefit of the non-Canberrans in the audience, kindergarten in the ACT means the first year of primary education. So I'm Kathleen O'Brien. I'm presenting the work of myself and my colleagues from the Academic Unit of General Practice, which is actually fairly unique in that we are part of both the Australian National University and ACT Health. I'd like to acknowledge funding that I received through the Royal Australian College of General Practitioners, and also note that the Kindergarten Health Check, which is the data set we used, is conducted by ACT Health. So by way of background and why we're interested, so we know mental health disorders are important in Australia, but they do affect young Australians as well. So 2013-14, there was a national survey of mental health and wellbeing of young Australians called Young Minds Matter, and found there that nearly 14% of boys and 7% of girls in kindergarten had a reported mental disorder, which includes behavioural and anxiety, depression type disorders. Developmental delay and disability are also important, and you can see from the ABS's 2015 survey of disability, ageing and carers that amongst children aged 5 to 14 years in the ACT, again, nearly 12% of boys and 6% of girls had a reported disability. So the Kindergarten Health Check is the data set that we used here. This is a really long-running annual survey of all ACT kindergarten children. So it's offered to all children in their first year of full-time primary education in both public and private schools. Over at the academic unit, we've got 20 years of data readily available. It's got two main arms to it. So there's a parent-completed questionnaire done at the start of the year, which includes information you can see there like demographics, health conditions, diet and exercise. And there are two standardised questionnaires included there that I'll talk about in the next slide. The second part of the survey is a physical health check, and that's conducted through the school year by the school health nurses, and that's where they do things like measure height and weight, check vision and hearing. And any concerns that are flagged during the survey process, there are follow-up procedures in place, referrals are made, and a letter will go to the child's regular general practitioner if that information has been provided. So for our project, we looked at the 2014 to 16 Kindergarten Health Check. So in that time period, there were 16,500 children enrolled in ACT kindergartens. There were just over 15,000 who participated in the Kindy Health Check for the first time. And you can see there that there were just over 14,000 children who participated in the full screen, which is the questionnaire and the physical health check, giving us an overall response rate of nearly 85%. So the two measurement tools we looked at for the key question here was, first of all, the Strengths and Difficulties questionnaire. So this is an internationally validated tool developed in the University of London and then validated for Australian children. It asks parents a series of 25 questions on various attributes of their child over the past 6 months, and then they get sort of scores in 5 subdomains, which you can see prosocial is one of the domains there, and the other 4 domains, emotional, conduct, hyperactivity and peer problems, they are combined to give a total difficulty score. Children are categorised based on the level of risk for those scores, so that'll be either close to average risk, slightly raised risk or high risk, and that's high risk of what is considered to be clinically significant risk of problems down the track. The second tool is the Parents' Evaluation of Developmental Status, which again is widely used, developed in the US, but again validated for us here. It's got 10 questions for parents, and essentially children are put on different risk pathways. Pathways A and B look at risk for developmental delay or difficulty. Pathway C looks at risk of behavioural and emotional difficulties, and a child can be on pathway C and one of A and B. And then we have children who have no reported concerns, which is pathway E. So as I said, we looked at the 2014 to 16 Kindergarten Health Check, and we included demographic data. We used a measure of socioeconomic status that was derived from the ABS's 2016 Index of Relative Socioeconomic Disadvantage, which was mapped to statistical area level 1, which is basically the finest geographical mapping we had, and that was based on geocoding of children's home addresses. 2 questionnaires I mentioned: parent-reported physical activity and body mass index derived from the measured height and weight data. We produced unweighted prevalence estimates, and they were unweighted because essentially this is a complete enumeration, so we didn't have survey weights in this case, and so that means we had we didn't need to impute data for that, that's what I mean. And then we did logistic regression, where the dependent variables were having a high risk strengths and difficulties score or being on one of the PEDS pathways. So the children in our study, they were on average, they were just aged 5.3 years, nearly 52% were boys, and 2.3% were of Aboriginal and Torres Strait Islander background. And as you might expect, the quintiles of socioeconomic disadvantage were reasonably evenly spread. Good news is that about 78% of children had a healthy weight based on their body mass index, and about 66% were getting 60 minutes of more exercise every day, and that's in line with the physical activity guidelines for children of that age. Looking at the risk scores, so the first graph on the left, which is showing high risk strengths and difficulties scores, you can see that on average about 5% of children had a high risk score for total difficulties, and the key kind of factors contributing to that, which you can see hyperactivity and inattention, that was over 8% of children were high risk there, and then conduct problems, and I guess reassuringly very few children were considered to have problems with their peers at 5 years of age. The other graph in the traffic light colours shows that actually about 10% of our kindergarten children are at high risk for developmental delay or difficulty, and I was surprised by how many children that were there, with another 20% at moderate risk, and we had about 25% having increased risk for behavioural or emotional difficulties, and overall 55% of children had no concerns reported for them. So a lot of information on this slide, but I'll just talk it through. So essentially these are the results of the logistic regression for the different strengths and difficulties subdomains. So each colour represents one of the subdomains we ran a model for, and the bars are clustered based on the explanatory variables. And I think really the take-home messages here of what we can see are that so boys in general had a higher odds of being rated at high risk on most of the strengths and difficulties subdomains compared to girls. So for example, the odds for a boy being classified as high risk for being hyperactive or inattentive was double that for girls. And with peer problems, the odds ratio was 2.73, so quite a significant difference there. You can also see that our Aboriginal and Torres Strait Islander children have increased risk as well, in a slightly different set of domains. That was for example, emotional problems, about twice the odds, and slightly lesser increased risk for conduct and hyperactivity. We saw some weaker results for things like physical activity, disadvantage and body weight, but we did see that socioeconomic status, the least disadvantaged group of children, which is the reference group, were less likely to have these disorders than the most disadvantaged children. Potentially reassuringly, whether it's a protective factor or not, we don't know, but we did see that children who engaged in more physical activity had lower risk of some of these problems as well. So similar results displayed for the PEDS pathways. So again, red is high risk of developmental delay or difficulty, and once again we found that boys were at significantly increased risk compared to girls, with an odds ratio of 2.12, and similarly Indigenous children had an odds ratio of 2.22. Can see actually looking again down there that physical activity, the column second from the right, shows that actually children who were exercising more had lower odds of being at high risk for some of the developmental delay or difficulty, which probably does make sense, but that's what we found there. So in summary, we found that boys are at greater risk of a range of behavioural mental health problems. So they're at high risk for conduct problems, hyperactivity and inattention, peer problems and prosocial behaviour. And they were also more likely to be at moderate to high risk for developmental delay or disability, and increased risk for behavioural and emotional difficulties from the PEDS score. And Aboriginal and Torres Strait Islander children are at increased risk for emotional difficulties, conduct problems, hyperactivity and inattention, and for high-risk developmental delay or disability. So what's that all mean? Essentially what it tells us is that for whatever reason, boys have increased vulnerability in early childhood. It's just raised the question of whether we need different approaches or supports for in early childhood for boys and girls. And also for our Aboriginal and Torres Strait Islander children, even within the ACT, we see they're vulnerable from a young age, just confirming that health inequalities are present throughout the life course. So, thank you.
Thank you, Kathleen, for that very interesting data. Just so much to take in. I'm sure we'll have some questions from the floor. Right at the very back row. That's all right. Getting some step count in this morning. Great.
Hi, I'm Naomi from the ANU. That was a lovely talk and really interesting. Thank you. I noticed on your last slide you had that boys were at increased risk of a variety of different behaviours, but pro-social behaviour is also listed.
Yeah,
that's a positive one, right?
In the graphs, well, yes. So pro-social behaviours are a positive attribute. Interpreting it, this is sort of consider it the other way around. This actually shows an absence of those. Yep. So for all the other qualities that contribute to total difficulties, a high score indicates high risk, but in this case it would have been low scores indicating.
So boys had lower scores. Yeah.
Yeah.
Okay.
Yeah,
thanks for clarifying.
Another question at the front, Ben.
Thanks very much. A great talk. I just had a question about these results. Is there any sort of idea that it might sort of be fed back to the schools and to those most at risk?
Yeah, so certainly because all schools participate in the survey, so results are absolutely, results are reported and therefore fed back. In terms of what we're finding here, I mean, it's really across all schools. So, and we're also finding that these results are repeated across the country. So, for example, the Australian Early Development Census, which is a census every 3 years of children of this age group, found similar results for boys and girls. So it does seem to be across jurisdictions and different sort of groups of children.
Right in the middle.
Thank you. It's very, very interesting. This might be a simplistic question, but I wonder if these results would be similar in countries where they keep their children at home or not at school until a later age. Some of these problems of conduct problems, hyperactivity and attention, maybe they need to be running around outside.
Yeah, there are certainly practitioners who think that. I believe it was Steve Biddulph is a psychologist who wrote about raising boys, and that's certainly his premise, is my understanding. I mean, I guess we can't tell that from these data, but it is a pattern we're seeing across the board. I think what would be really interesting is what we don't know is whether that risk persists throughout schooling for boys and girls, whether those differences remain or if it changes as they go through school. The Young Minds Matter survey did look at children of all ages, and in their results, for example, they found those differences between boys and girls held through primary school and early high school, but for children in adolescents in years 11 and 12, it actually was reversed, that girls had a higher risk. Having said that, higher proportion of mental health disorders, but having said that, that's not a time series, that is a snapshot in time, so what it doesn't tell us are things changing for boys and girls, or does it, with time, or does it change for individual boys and girls as they grow up?
And what I wonder is, I just know when my child was at school, these little boys who just can't keep still, and then they're the naughty kids, and so that sort of sticks.
Yeah.
And then the behaviours, you know what I mean? So
I do.
There's this snowball effect. So I wonder if you followed these kids through.
It'd be interesting, wouldn't it? I mean, I really remember my little brother when he started school, and he was such a good boy. Like, he would sit still at school all day, and he just had to wrestle and play as soon as he got home. Yeah, and I don't remember noticing that with my little sister, but that's just two people. And I don't know. I mean, certainly, these children are very active, and I think one of the things we found is that boys had higher were more likely to do exercise for 60 minutes or more a day, as reported by their parents. So there's a lot to untangle in there, and I think it would be really interesting to be able to take it further.
Well, thank you, Kathleen, for a great finish to the session one. Please join me in thanking Kathleen for her presentation.
Thank you.
And thanks to all our speakers this morning that have given us lots of food for thought about all the different parts of our bodies, I think. So please join me for some morning tea, which should be ready shortly, and back for 10:50 for our next session, session 2, which will be lots of more interesting stuff, but a bit more nursing focus and a bit more primary healthcare as well, I think. So we'll see you then.
Okay. Welcome everybody to the second session for the day, day 3. We've got 5 speakers today. We've got Rory Maguire, who wasn't on the program for today. He was on yesterday, but he's coming in today as he couldn't make yesterday. So this session is public health type presentations, quite different from this morning, I suspect, and a dual focus on infants and elderly. So it looks like a really interesting bunch of presentations. I think we'll just get straight into it. So I'll introduce Naomi Clark, who's the HDR paper for today's session, and she's going to be looking at optimising control programs for soil-transmitted helminths. Thanks.
Hi everyone, thanks a lot for having me today. So my name is Naomi. I come from the Research School of Population Health over at the ANU. I submitted my PhD thesis a couple of months ago now, and my thesis topic is optimising control programs for soil-transmitted helminths. So I'll do my best to take you through the key findings and implications of my thesis in just over 15 minutes. There's a lot of information, but I've tried to cull it down to the main findings, so I hope find it interesting. So what are soil-transmitted helminths? I'm going to refer to them as STH for the rest of this presentation because it's a bit of a mouthful. And I will say that I'm very glad for once I haven't been given the slot right before lunch, because people tend to report that they can lose their appetite with my talks because STH are intestinal worms. So STH actually comprise a few different species of intestinal worms. You've got, sorry, these are the only pictures. You've got the roundworm, you've got the hookworms, and you've got the whipworm. These all are slightly different worms. As you can see from the pictures, they look different, but they have some important things in common, which is they're all parasitic worms that infect humans. They all live in the gastrointestinal tract, and they're all transmitted through soil, which is contaminated with human feces. And STH represent one of the world's neglected tropical diseases. NTDs are a group of infectious diseases that tend to affect people who live in poverty. And the reason they're called neglected is because historically they've received very little funding and attention compared to other diseases like, say, HIV/AIDS or malaria. This slide's just to illustrate the distribution of STH globally. So the darker green represents higher prevalence. You can see that the disease is really clustered in Africa and in South and Southeast Asia, with also some disease over in parts of Central and South America. It's estimated that nearly 1.5 billion people worldwide have intestinal worms. 1.5 billion, that's about 20% of the global population. So it's exceptionally prevalent. And the disease burden's estimated at 3.5 million disability-adjusted life years. That mainly comes from heavy intensity infections, and it comes from things like iron deficiency anemia, and also from impacts on child growth and development. So the really tragic thing about STH and other neglected tropical diseases is that they don't just happen in people who live in poverty, they perpetuate poverty. So when you have things like, excuse me, like impacts on children's growth and their cognitive development, that becomes harder and harder for families and children to lift themselves out of that poverty cycle. So how do we control STH? The good news is that in the last decade or so, there's been a really strong concerted global effort to improve STH control and that of other neglected tropical diseases, and that's come from the World Health Organization, from ministries of health in endemic countries, and from lots of other partners, including large funding bodies like the Bill and Melinda Gates Foundation. So STH control focuses on regular delivery of deworming drugs to at-risk populations. So in practice, what this looks like is that countries have a deworming day or a deworming week, once or twice every year, where lots and lots of people go out and deworm at-risk groups in the community. The drugs that are used are albendazole and mebendazole. These are donated. 600 million doses are donated each year by large pharmaceutical companies to control STH. And the aim is to decrease infection intensity and therefore reduce the morbidity associated with infections. And because the majority of infections are seen in the majority of morbidity is seen in children, these programs tend to focus really strongly on school-aged children and preschool-aged children. So drugs are delivered at school and drugs are delivered at child health days along with immunisations. The other component of STH control that's thought to be very important is improving water sanitation and hygiene, or WASH, conditions. Basically, without inadequate WASH, you can't have STH transmission. So as I said, it depends on the soil being contaminated with human feces. So if people are defecating in toilets, you don't have STH transmission. If people are washing their hands, they're not ingesting the worm eggs, you don't have STH transmission. So it's felt to be an important component of STH control. So what we've got is a disease that's exceedingly prevalent. We've got a significant burden of disease. We've got it perpetuating poverty. And we've got lots and lots of effort going into controlling this disease with lots of resources committed to STH control. So we really want to make sure that we're doing the best we can with these resources and optimizing the control. But there are some evidence gaps in terms of how best to control STH. And that's what I looked at in my thesis. So today I'm going to talk to you about 3 key evidence gaps in the knowledge on STH control. And each of those evidence gaps will map to a research question in my thesis. So the first evidence gap is the efficacy of deworming or anthelmintic drugs and drug combinations. So I mentioned albendazole and mebendazole are used. They're great. Not so good against whipworm, good against roundworm and hookworm. There are lots of other drugs out there, but no one's actually done a comprehensive comparison looking at how these drugs compare. So my first research question is, what drugs should we be using for STH control? Secondly, I mentioned that treatment is usually tailored to kids, school-age and preschool-age children. It seems logical that if we treat more people, we treat adults and teenagers and babies, that we could probably improve STH control. But no one's actually looked at that empirically. There's no evidence comparing different strategies. So my second research question is, to whom should STH control programs be delivered? And finally, I talked about the fact that WASH is likely to be important in STH control, but there's really little evidence. It almost all comes from cross-sectional studies, which is considered quite weak evidence. So my third research question is, what is the role of WASH in STH control? So what I'll do for the next 5 minutes or so is take you through each of these research questions, give you the main methods I use to answer these questions and the key findings. So for research question 1, what drugs should we be using for STH control? I did this using a meta-analysis, which was published in last year. The aim of this study was to compare the efficacy of a wide range of anthelmintic or deworming drug regimens. So I systematically identified papers that compared the efficacy of 2 or more drugs, looked at the relative risk of cure between those drugs, and I used what's called a network meta-analysis to compare all those different drugs to single-dose albendazole. This is just to show you that it was a really complicated network in the study. I had 21 different drugs and drug combinations, lots of studies comparing different combinations of those 2. So let's just say I was really happy that the calculations were done by a computer. So the key finding from this study is that for whipworm, which is the STH that's generally quite challenging to control, if you look at this line in the middle, this represents sort of equivalent efficacy to the current standard, which is single-dose albendazole. So anything to the right of this is more efficacious. So we've got 6 different drug regimens that are more efficacious than what we're currently using. These 2 aren't really useful because they require multiple dosing over multiple days, which isn't really feasible in practice. This one, mebendazole and ivermectin, not so great because it's not very good against hookworm. So we've got 3 drug combinations that currently exist that are better at treating whipworm than what we're currently using. And these are likely to be able to enhance STH control programs by improving the efficacy against this parasite. The great news is that one of them, albendazole ivermectin, is already in widespread use. We know it's really safe, and so we could start using this now. The other 2 still need a few more safety trials. They haven't been done in enough studies. One of them's not even licensed for human use yet outside China, so there's more work to be done on those combinations. Okay, moving on. Research question 2. To whom should STH control programs be delivered? I looked at this in a number of different ways. Firstly, in another meta-analysis. I wasn't planning at the start of my PhD to have 2 meta-analyses, but that's how it worked out. This paper was published in 2016, and the aim was to examine the differential impact of mass, so community-wide deworming, versus targeted deworming, so deworming only to children, on STH prevalence among school-aged children. So I systematically identified papers that reported STH prevalence before and after this deworming, calculated the prevalence reduction, and then ran a generalized linear model that adjusted for confounders like baseline prevalence and treatment schedule, so how many doses, how far apart, that kind of thing. The results of this paper are really quite powerful. So what we found was that for both roundworm and hookworm, giving mass treatment compared to targeted gives you a significantly greater odds of prevalence reduction. It makes sense, but this is the first time it's actually been demonstrated empirically, which is what's really needed to inform policy. We didn't see the same trend for whipworm, and we think that's because the drugs just aren't efficacious enough to see a prevalence reduction for either strategy. So we did a meta-analysis. We found that it's likely that expanding programs to whole communities will help, but we wanted to test this in the field. So we did a field-based study in East Timor, and this was really the main component of my PhD in terms of field work. I coordinated the study. I went to Timor for 6 months to run the study. I loved it. So the aim of this study was to compare the impact of STH control programs when delivered to whole communities versus when delivered only to school children. So we did a pilot study in 6 communities. In the control arm, we just went to the schools, we gave them deworming, and we complemented that with a wash program. In the intervention arm, we also gave deworming to the entire community, so all age groups except for pregnant women and babies under 1, and we complemented that with a community wash program. And we measured infections at baseline and at 6 months follow-up in children. So the results of this study, in the blue bars we have the baseline hookworm prevalence, and the orange we have the follow-up, so after the intervention. Left is the control and right is the intervention. And we can see that hookworm started at about 15% in both study arms. In the control arm, it decreased to about 10%, which is a relative prevalence reduction of 52%. And in the intervention arm, it reduced to 5.7%, so a relative prevalence reduction of 88%. So there's a difference there. Given that it was a small pilot study, when we ran a fully adjusted model, we did see a lower odds of hookworm infection in the intervention arm, but it didn't reach statistical significance because this was only done in 6 schools, not the 50 we probably required to see a statistically significant result. So the conclusions for this research aim is that there's evidence now from a systematic review and from a pilot study supporting the benefits of expanding control to whole communities, but we need bigger trials, well-designed cluster randomized control trials. And we also need to think about the fact that we need to go from 600 million drugs to probably closer to over 1 billion drugs a year. So that's an important consideration for people who are involved in planning STH control. And my final research question is, what is the role of WASH in STH control? So this question we answered using another field-based study in East Timor. This was a fully powered trial. I wasn't involved in the actual running of the trial. It finished just when I started my PhD, but my role was to conduct a statistical analysis of this trial. And the aim was to compare the effectiveness of a community-based wash and deworming program to deworming alone. We did this in 18 rural communities. The control arm received only deworming every 6 months for 2 years, and the intervention arm additionally received a wash intervention at study baseline. And that involved improving their water system, promoting household sanitation, and conducting education sessions about hygiene. And we diagnosed STH infections across age groups every 6 months for 2 years. So what we found was from baseline to the end of the study, 2 years, we had a reduction in hookworm prevalence from about 60% to about 15%. But the 2 different lines, the solid one and the dotted one, represent the 2 study arms. And as you can see, they're basically identical. And in our adjusted model, we indeed found that there was no difference in the risk of hookworm infection at any follow-up time point. So this was surprising, disappointing, because we thought we would see a difference. We thought we would see that the communities that received WASH had a lower hookworm infection prevalence. But what we think is the reason is that although we saw a good decrease in open defecation in the intervention arm following the WASH intervention at baseline, it never got to 0, and in fact it crept back up closer to 40%. And it really only needs a couple of people open defecating to continue the transmission of eggs in the environment, and so that's the most likely plausible reason for why we didn't unfortunately see an impact of WASH. So it may be that WASH interventions need to achieve higher coverage and in fact achieve open defecation-free status to have an impact on STH transmission. And it also may be that because deworming is so effective, it's actually difficult to see an impact of WASH, and in fact the role of WASH might be more once we have stopped deworming to prevent transmission from actually re-emerging. So that is the whirlwind summary of the results of my various studies that I did for my PhD. I want to just finish by giving some implications and future directions. So we all know that the ultimate goal of research in health is to benefit the communities and the people affected by the disease. And I'm really fortunate to have done my PhD when I did, because we're approaching a really critical time for STH policy. So all the guidelines, all the targets, all the efforts are focused right now on these goals that were set by the WHO for 2020. It's now 2019, and there's a lot of discussion and debate happening about what should STH control look like after 2020, what are our goals, what are our targets, what should we be doing? So it's a great time to be putting this research out there and trying to have an impact on that policy going forward. So what I want to do is just for each of my 3 research questions, give one key takeaway message for policymakers and one key future research direction. So research question 1, what drugs should we be using for STH control? In terms of policy, we need to prioritise adding the ivermectin-albendazole combination in STH control programs, especially where whipworm is predominant. In terms of future research, we do still need larger trials of promising drug combinations, and we do still need more research into new drugs that, because there's always a risk of drug resistance emerging. Second research question, who should we be delivering STH control programs to? Policy implications to prioritise expanding STH control programs to whole communities in areas where prevalence and intensity of infection are high. Future research, we still need bigger field trials comparing mass and targeted deworming, which is what I'm doing as part of my postdoc now. And the role of WASH, this is a tricky one because our findings didn't give us the message that we wanted to give to policymakers. So what we're focusing on is that we really think that WASH interventions need to achieve high and sustainable coverage in order to optimise health benefits, and future research should focus on the role of WASH in transmission after we stop giving deworming drugs, because it's not something that we can continue doing indefinitely. Thanks a lot for listening. Happy to take any questions. I didn't have time to read them all, but you know, lots of people helped me with this project.
That's really fascinating, Naomi. Are there any questions from the floor? Not yet. Can I ask a question?
Please.
You focused in the second topic area on control. Is there a move towards sort of eliminating this, and what would be the status of that sort of work?
It's an interesting question. There is definitely a focus on transmission interruption or disease elimination in the academic literature. Yeah. There's not a focus on that at all in policy. The policy is all about reducing morbidity and achieving control. So the WHO talks about elimination as a public health problem, but they don't talk about transmission interruption. But there's a lot more research going on. There's been mathematical modelling that has shown that it is feasible in most transmission settings. I mean, we know it can be done because, you know, we used to have STH in Australia. There used to be STH in countries like Japan and Korea, and they've eliminated it essentially because they've had economic development and now everyone uses toilets. So we know it's possible, but it's very complex to achieve that in, you know, in low-income settings. So there's a big research study underway in India and Malawi and Benin, I think, looking at the possibility of transmission interruption, but the difficulty is we don't actually know how to define that. We don't know how to measure it. We don't know, you know, once it gets to a certain prevalence, is it lack of disease in the environment? The eggs can survive for up to 2 years, so it's really quite challenging to achieve, but we know it's possible. Yeah.
Naomi, thank you. That was fascinating. There's a lot of Australian researchers in the region, and particularly in Timor. Did you find any sense that any of your subjects felt over-researched by the number of Australians that are turning up in Timor to do research?
In Timor in February this year, doing a project that was an unrelated project, but we went back to some of the same schools from my study. I think my pilot study was in children, and they just think it's amazing. You know, you get big trucks rocking up, and you know, a whole bunch of people, white people, local people, and asking to give the poo. Like, they just think it's hilarious. So I don't think with the children it was a problem. I think some of the parents. We did see, you know, a drop-off in parents coming back to the school at follow-up, and then again when we went back in February we saw another drop-off in parents. So I think there is some sort of like, aren't they finished yet? But I think because we're going in, we're not just going in and saying we need this from you. We're going in and, you know, in the project I did, we were giving deworming tablets, we were doing improvements to WASH. So I think communities feel like they're getting something back in exchange for their willingness to participate in research. The WASH for Worms trial in adults engagement. Adults are much less willing to give samples of poo, especially 5 times over a 2-year period. So that required really quite intensive community engagement. Our team would go and stay in the villages for 3 or 4 days and work really closely with village leaders, and we generally managed to get quite good engagement, but we did lose one community along the way because they were just a bit over it.
One last quick one.
I'm interested
I'm assuming that you didn't include pregnant women and children under 1 because the risk is too high. But what's the risk of them not getting treated?
Yeah, so that's the World Health Organization guidelines are to exclude pregnant women and children under 1 just because there's not enough evidence. Actually, it's only pregnant women in the first trimester. There's not enough evidence to show that the drugs are safe in this age group, although it's in these groups it's likely that it is. I guess the thing about deworming programs is that they keep going. And so once the woman's had the baby or the child turns 1, they will start getting treated. And it's also much more, these deworming programs, they don't go in and say, okay, you've got a worm and you've got a worm and you've got a worm, so we'll treat you. They treat everyone. So it's more about the impact on community transmission. And you're never going to get 100% coverage. So it's more about reducing that overall disease burden. But it is important that deworming programs, don't just go in once. So fortunately for us, after our project's finished, very fortunately just after, because it would have been a big problem if it had started during our projects, the government started a 5-year community-wide deworming campaign across the country. So hopefully the people that we missed will have been treated at some point.
Okay, I think we'll wrap it up. Thank you very much,
Thank
Sam.
you.
That was great. Okay, our next speaker is Karen Strickland. She's going to talk about elder abuse. So she's going to talk about supported decision making to assist older persons experiencing elder abuse, and that's systematic review. Thank you.
Okay, thank you for the opportunity to speak about this review that we did. Supported decision making to assist older people experiencing elder abuse. This was part of a funded study funded by Adicus, a local advocacy agency, and conducted with Kasia Bale, Sarah Cope, Murray Turner, and latterly Cameron Moss. So making choices about our lives, our daily lives, is something that we all take for granted. What time to get up, when to eat, when to go to the doctor, etc. And I don't think any of us would think that there is actually an age limit on that. However, the United Nations have highlighted in 2006 that being able to make decisions about your daily life is actually a human right. And there is a continuum here around autonomous decision making, and I think in healthcare we're quite used to shared decision making models. Supported decision making is something a little bit different and closer to our autonomous decision making on that spectrum. And it's really the ability to make decisions through being supported with all of the relevant information and able to make that decision independently. However, within older people, we know that about 10% of the older population worldwide sadly experience abuse, and that is actually an estimate because quite a lot of that older abuse is unreported. Elder abuse is defined as any act that causes harm, so that includes physical, social, psychological, sexual, and also financial abuse. And often perpetrators of abuse can be close family members. So some of the challenges of elder abuse and its nature is that it can start quite mildly, and often unintentional cases of neglect make it quite difficult to report. And also in the older population, cognitive impairment and dementia can make abuse difficult to detect, and particularly financial abuse. We know with the Royal Commission in Aged Care at the moment how missed care and care rationing can also affect the older population. So the aim of this study was to look at the evidence-based underpinning supported decision-making models to apply to the advocacy sector for older people who are experiencing abuse. So we conducted a systematic review of the literature. We used a robust, the PRISMA methodology for that, and we were very inclusive. So this wasn't just a systematic review of RCTs in the way that traditional systematic reviews. So we screened over 1,200 papers, and we also found that there was very little within the context of older people. So we also included papers that focused on people with mental ill health and also intellectual disabilities, where supported decision-making models are also used. We included 6 review papers as well and 17 empirical studies. There was only 1 RCT within that. Most of the papers were qualitative papers and a number of PhD theses that were involved in looking at developing frameworks for supported decision-making. And we did a content analysis of all the papers, and there were 4 key themes that we arrived at. And the first one, the personal and environmental factors, this really was related to both the decision maker and the support person. The decision-making experience and disability characteristics, coexisting conditions, emotional factors were all found to be significant contextual factors that could either enable or inhibit supported decision-making, with previous experience and preferred styles of decision-making being quite influential. The issue of capacity was also raised in a number of the papers, and most prominently featured in papers that related to people with dementia or intellectual disability. The relationship between the decision maker and the support person was also identified in a number of papers as a strong influence on the enablement of supported decision making, with the relationship between the decision maker and support person bound with relational closeness. So ideally you want someone who knows the person really well, knows in fluctuations in their health, well-being and capacity. So that's seen as pivotal to enhancing decision-making of the ability of a person. But bearing in mind that some of the people who are perpetrators of elder abuse are also close family members, it does suggest that the role of advocacy supporters, they need to get to know that person really well. Information and training. Several studies identified the need for adequate information and training for supported decision-making for the individual and also for the support persons and professionals who engage in the decision-making process. A number of studies, 4 studies, found that the term supported decision-making was poorly understood by the person, but also those who are supporting them. And Gooding also noted that there were reservations about supported decision-making as some older people perceived that it actually supported abuse and exploitation, and there was some concerns over the lack of training for the support person. So a number of studies pointed towards the recruitment and training of support persons within advocacy agencies to be looking at qualities such as being neutral, being able to manage risk, avoiding influence, and not being realistic too soon to enable the person to make that independent decision themselves. And the study by Bigby et al. In 2017 also pointed towards ensuring that there were adequate opportunities for thinking through issues, so supervision, self-reflection, mentoring and role modelling was seen as important to supporting the decision support person. We were also keen to look at the models and frameworks that helped to support the environment for supported decision making. But it is a complex and multifactorial process, as you can see. And one of the key factors was that there can be changes in the cognitive ability and health status of the individual. And so any changes should be reassessed at any point within that person's journey. So once we choose a particular support for decision making, it's not that you would always do the same kind of support. So this review did uncover some models which have mostly come from qualitative pieces of research that have developed those frameworks. And that's helping the support person to understand the context and the person to identify the decision-making preferences of the individual making those decisions. A number of studies also highlighted the role of financial counsellors as providers of information, support and advocacy for those in financial difficulty. And West and Ramcharan 2019 found that financial literacy in older people was also an issue. And they suggest that there may be a role for the advocacy sector in the development of financial literacy. We found one study done by Pasaya et al. In 2016, and they developed an evidence-based intervention for the banking sector to identify people who might be at risk of financial abuse. So that was done across the Australian banks. And this tool was developed as an intervention to highlight potential cases. This hasn't been trialled out with the banking sector, but it might be a tool that could be used and researched in health and also advocacy agencies to try to identify that form of abuse. But further research is needed for that. So the review, we did adopt a systematic approach using PRISMA. We also had independent review of the articles to restrict the bias. We did find, obviously there's a lack of robust evidence, but perhaps that's due to the fact that Article 12 in the United Nations document has only relatively recently been imposed, so supported decision-making models are still relatively new, only within the past 10 years. So further studies really are required, and particularly in the advocacy sector and health. So finally, we acknowledge the funding, and we're really grateful for the funding from ACT Aged Care and Disability Advocacy Service. And finally, we'd like to dedicate this work to Sarah Cope, our friend and colleague who sadly died during this work, but her passion for aged care and the rights of older people really influenced this work. Thank you.
Thank you, Karen. We're running a bit behind time, but we do have time for a quick question or two. Does anyone want to offer up a question? Can we ask what's next? Following the findings of your systematic review?
So this report has been given to ADCUS and part of the OPAN network as well. So we're hoping that it will influence some of their policies around supported decision making, and that the tools will be helpful within that sector. We're just finalising the report for publication, but certainly I think there are opportunities for further research around testing some of those models and frameworks within the advocacy and health sectors.
That's terrific. Well, thank you very much. Now, next we have Catherine Angus. Yes. She's going to be talking about us smartphone apps used for breastfeeding and their response to infants experiencing suboptimal feeding. Thank you.
Right. Thanks, everyone. So I've come down from Brisbane. This is not backyard research. I'm here with my supervisor, Dr. Sue Gledhill, and my other two supervisors, Dr. Lynn Dunn and Dr. Sandra Miles, have stayed home in the sunshine, which was probably a good idea. So we're talking about smartphone apps and how they influence breastfeeding. We know that 98% of women want to breastfeed, and we tend to talk about breastfeeding socially as a lifestyle choice rather than a health imperative. But even if we talk about it as a lifestyle choice, 98, sometimes 95%, depending on where we've looked at intent, 98% of women want to do it. And 96% of women start breastfeeding in Australia. We've got one of the highest breastfeeding initiation rates in the world. At 2 months, 51% are exclusively breastfeeding, and at 4 months, 39% are exclusively breastfeeding. At 6 months, that goes down to 15%, which is not really in line with the World Health Organization or NHMRC guidelines that exclusive breastfeeding be for the first 6 months. So those intention figures don't necessarily reflect duration. We don't know how long women intend to breastfeed for, but we know that they want to, and we know that they're not getting there. So families are increasingly looking for extra support. They're looking at the internet, and with the ubiquity of smartphones, they're turning to smartphone apps used for breastfeeding. And there's heaps of them out there. These are 3 of them. There's another 100 where they came from. Each of these 3 have got over 500,000 downloads globally. So they're using them. And the middle one in particular we'll talk about a little bit more later. It's fascinating that an app that is designed and marketed as supporting breastfeeding uses a bottle as its icon. So they want them, whether they're any good or not, whether we think we are offering adequate support or not, women are downloading these. And it's not just women, it is all parents, and some are designed that way, but really, mostly we're talking about women. So, thing is, we don't know a great deal about what's out there. There's a few studies that we wanted to look at. The first one, from up in Queensland, looked at pregnancy apps and fetal movements in pregnancy and found that a huge number of those apps are giving out trash information. Things like, we know that baby movements are really, really important in pregnancy care, but they're giving information like it's normal for babies' movements to slow down in the last weeks of pregnancy. There's no evidence to support that, and more than 30% of apps were saying that. In the second study, it looked at apps of all backgrounds, so not just commercial apps, but non-profit apps, a couple of government apps, apps from what I would call both allied and competing interests. So perhaps a large company that manufactures breastfeeding support equipment, but also companies that manufacture breastfeeding or breast milk substitutes are putting out apps to support breastfeeding. I think that's a really big conflict of interest, and I would love to look at how well they're doing that. So that study found that they offer information, there's not a lot of interactivity, they don't take into account the actual information that is individual to that baby. And the quality of the information wasn't assessed. They just looked at how many apps offer information. And the last one that we looked at 41 different apps, considered diversity content, and found that 87% just show white women breastfeeding, which probably feeds into a lot more of our social understandings of breastfeeding, and found that only 13 of those 41 apps that had actually really had any valid educational content at all. So there's not necessarily a lot there, but that's about as much as we know about smartphone apps used for breastfeeding. There have been lots produced academically, and they seem to be produced on a small scale, and then they're evaluated, and then they sort of disappear into the ether. So what we're seeing is that the evidence-based apps aren't popular, and the popular apps aren't evidence-based. So I really wanted to explore those apps that haven't been studied, the ones that we don't know much about, that are put out by commercial producers with little clinical input. Our initial aim was to take a fake profile and run it through a series of apps and see what would happen, and particularly in the environment or the context of a baby whose feeding was diminishing and not a baby who wasn't doing well. We really started to look at that and manipulate it based on a case study, and then we thought we'll push it so this baby's about to fall off the perch and see, are any of these apps actually going to do anything about it? A lot of them have tracking features, how long did your baby feed from, which side, how many wet nappies, all really useful clinical information, but are they going to do anything? Are they going to refer women to support services? Are they going to say, your baby has fed 15 times in 24 hours and that's completely within the normal range? Because women really seek credible affirmations and reassurance. Unfortunately, our research office has some concerns about breaching terms and conditions, and so we're not able to do that at this stage. And maybe that study needs some rejigging. So instead, having seen how many of those apps use varying symbols to represent breastfeeding, we're going to do a content analysis exploring that instead. So some of the things we are considering: do smartphone apps provide support for breastfeeding? How do they do it? What do they do? What symbols and representations are commonly used? And maybe later on we'll look at how that influences breastfeeding attitude, because we know that exposure to formula or breast milk substitutes in the first week decreases breastfeeding continuation. But how does an exposure to a bottle or imagery affect that? And we don't really know. So I've come back to this one. And we're only going to look at apps that market themselves as being for breastfeeding support. So not infant feeding, because I think that's quite reasonable. If it's an expressing app or a bottle feeding or a daycare app or something that is there to support infant feeding more broadly, it's not unreasonable. It's not necessary, but it's not unreasonable to have a bottle there as imagery. But when you're marketing yourself as supporting breastfeeding, I don't think an image of a bottle is the most supportive thing you can have. And in my preliminary searches, I reckon it's about a third that are using that. And there's a surprising range, and I want to look at how many ways in these apps breastfeeding is represented. There's some really interesting ones. There's, a little symbol of some cleavage or a milk droplet. Some of them even go so far as to do a stylised nipple. But this coming up, another thing I've noticed is that for those of you who use iPhones, in your predictive text, if you type baby, the bottle emoji comes straight up. Are we really supporting women to succeed in their breastfeeding goals if we're just throwing bottles in their face all the time? So what we're doing is a systematic review of literature around breastfeeding apps, and there's not a lot, as I mentioned. We don't know a huge amount. So we're just looking at features that will support women to breastfeed. At this stage, that looks like it might be things like video conferencing. There's a lot of research coming out about that and about peer support, and maybe we can use that to help. And we'll be looking at the image data from breastfeeding apps, which is a lot easier to access because it's all publicly available. We don't have to download the apps. I don't have to pretend to be a breastfeeding mother. I definitely don't have to get up in the middle of the night to feed a baby I don't have, so I'm quite looking forward to this angle of the project. And so we probably won't gain quite the understanding I first wanted, but with a bit of a rework, further study will give us that. But we will have some understanding of the ubiquity of images that I consider unsupportive of breastfeeding. That is where we're up to.
Thank you, Catherine. Very topical talk.
Yeah, it's World Breastfeeding Week. I forgot to mention that. Happy World Breastfeeding Week, everybody.
Questions? Comments? Next steps, Diane?
Catherine, thanks for that. That's clearly women have, as you say, have an appetite for apps to assist them. I can see why you don't really want to be going out all the time when you've got a new baby. But you imply that probably the most important thing about an app is signalling where there are significant problems that need to be addressed. But is that what you meant to say? That's what I got out of it.
One of my concerns, and I think this comes from my own practice, is seeing women are seeking validation, and I wanted to see if they're getting any of it from the app. Some credible affirmation that, yes, you're doing a good job. We also know that low milk supply or perceived low milk supply is one of the leading reasons for breastfeeding cessation. So, and everybody seems to assume they don't have enough, even though physiologically we tend towards having too much. But women do tend to assume that they don't have enough milk, and so I just wanted to know, is this why they're using the apps, and what are the apps really doing? We just don't know a great deal about it.
Yes.
Thanks so much for that. That was really interesting. I guess that's a comment and maybe a question, but it kind of mirrors so many other areas of health, apps, Facebook, forums, Dr. Google. So, it just points more and more to me about the health literacy of the people that we're working with. And as clinicians, more and more we're having to help women interpret the information, or as midwife, that, you know, that they're finding in these forums. And you know, for a while now, I've thought about whether we need some sort of framework or tick of approval that health professions or organisations can kind of say, look, this is a good app, or this is a good website, or some way to help women or health patients in general, you know, make their way amongst all this sort of information.
Yeah, I think that would be great, and I think we've made a lot of efforts to do that academically, but there's not great uptake. And the way that the review and rating system works seems to me mean that the free apps just get powered up the ratings, and the more people who are using it, the higher up you'll get, whereas these small academically based apps don't seem to achieve that, and so they can't. And it seems that apps are being downloaded based on a picture almost, or their graphic design rather than their informational content. So the health literacy is really important. It's interesting too that from a socioeconomic perspective, women of a lower socioeconomic background prefer to get their information from peer sources. They'd rather be getting it from Facebook than to be getting it from a health professional almost. And sometimes I wonder, are we actually just breeding so much distrust in them that they want to go and seek information from elsewhere? Because I see it all the time, that the breastfeeding information that is just inaccurate that's out there from us as health professionals, but also in society, is rampant, and I don't know how to tackle it, but I need to know what's there before we can do it. There was one more at the back somewhere.
One last, Jane.
Thank you very much. I've got a sort of questions, comments. I wonder if a lot of people, you mentioned lower socioeconomic background, people from those backgrounds are less inclined to go to a health professional. Perhaps they find it a bit intimidating. And I wonder if the academic apps have been co-designed with breastfeeding women. So they do like pictures. I like pictures. I love shiny, colourful magazine covers. I'm a marketer's dream. So maybe that's the problem, that they're a bit too academic.
Yeah, maybe it is. There are some that have been co-designed and have reasonably good results. It is so interesting to see that of that imagery that's used, it's almost all white women. That's a little bit, I don't know whether it's disappointing. Is it white women who are using the apps, and are they using it because there's photos of white women in the apps, or are there photos of white women in the apps because that's who we're marketing to? I don't really know. There is so much more to understand in this, but we know that there's obviously an enormous appetite to it, so we need to understand it.
So are you going to develop one?
Maybe. I have had this discussion with the Interaction Design School at University of Queensland, and they would love to collaborate on making something happen. I also work with the Australian Breastfeeding Association, who are currently developing one, and I have been involved in that project. So maybe.
Okay, that's all we've got time for. Thank you, Catherine. That's terrific. Okay, our next speaker is, I think, Dona Dolphus, improving the care of patients with behavioural and psychological symptoms of dementia in acute care. You do, great.
This one? Is it to swap? Okay. Do you want to start?
Hi everyone, thank you very much for having us. My name's Kasha Bale, and this is not Donna, this is Maya. Donna unfortunately was unwell yesterday and is still unwell today, so I'm very sad that she won't be able to present with us, because this is a very exciting opportunity where I've been working with the nurses as part of a practice development scholarship here at University of Canberra and Canberra Hospital, for them to do some work in looking after their client population. So Maya, would you like to continue?
My name is Maya Zwickel. I'm a CNC of the acute care of the elderly, or commonly known as a Ward 11A. And I just would like, our project is improving the care of the patient with behavioral and psychological symptoms of dementia or BPSD in an acute care setting. and it's in conjunction with the University of Canberra and the Synergy Nursing and Midwifery Research Centre. And I would like to acknowledge also Neri Bullman, who was the initiator of this project.
And Maria, who's done a lot of the work on the project too, we'd like to thank very much.
Who was our research assistant. I would like to start with the case study. 60 years old male patient admitted to Canberra Hospital, to one of the medical wards, with hematuria and permanent indwelling catheter. Patient has dementia, and patient lives alone, at home alone, with no family or he had a family but no support, estranged from his family, and he had any social connections or friends. He had also had no EPO, enduring power of attorney. Patient has been non-compliant, agitated and aggressive, and had something in between 7 to 12 code blacks in a medical ward he was at. And code black is, it's basically displaying aggressive behaviors, trying to abscond. He was a wanderer, and he was admitted to medical ward because he had some issue and medical issue, not the aged care issue. And medical ward, as you know, it's free to go. Patient can come and go, and it's not an ideal for wandering patient. We were asked to take this patient on to our unit because we do have closed doors. We have a code. You need to press the code to come in or go out. He still was under the care of a medical team and came to our unit distressed. Since he was non-compliant, with his medications, or treatment, or personal care also. Patient has tried to abscond, and what strategies we put in place to de-escalate the patient. What we used to do, we do, as I can say, maybe supervised absconding. We just have tried to, patient had, I have to say that patient had in medical ward, he had a special, which is AIN usually, or other staff member who will look after patient one-on-one, and they had literally stopped the patient from going. And what we had supervised absconding, as I said, and patient was walking, going out of the unit. We do initiate code black in this instance just for like a safe net, probably, but we do instruct the security people not to touch the patient or not to talk to patient, because we would like just to de-escalate the patient, talk to patient, and follow the patient to understand where he is actually going. And what's happened with this patient, he went out, and the first thing he did, he went to Zuki. And he had his wallet in his pocket. He took his wallet out, and he bought himself a sandwich, and then he came back. The patient came back, and that's what patient was doing. It's the first time. The second time he absconded. Patient went out, and he had a smoke. As he's not allowed to smoke inside the hospital or near the hospital, that he had to go out of hospital and have a smoke. And that in this point, patient, we had no probably physical aggression experience from this patient, and patient was quite pleasant and half compliant. I can't say he's totally compliant, but at least we have managed to give him some personal care, some medications, and treat his hematuria. I probably need to move on. Yes. This is acute care of the elderly, or Ward 11A. We had last year in January, we have had big refurbishment is now on the ward, and we have 19 acute beds and 5 beds for geriatric special care unit, which is dedicated to dementia-specific and behavioral issues. I just have to say that this particular patient was not in this unit. This is another closed unit. We tend not actually, and it's quite average size, I would say, and there is no place for wanderer to wander. We do have, now we have the garden, which was also refurbished, and we have a bit of a more space for wandering, but the general 19 beds side is better for wandering patients. This a couple of definitions by Australian Commission on Safety and Quality in Health: cognitive impairment, difficulty with communication and speech, difficulty in memory, attention in thinking or judgment. And it's patient admitted to us, some patients admitted to us with dementia, some with delirium. Dementia or common form of dementia is Alzheimer's disease. As you know, it's terminal disease and is irreversible. Delirium is can be an acute episode and can be reversible. This is just some statistics in regards to dementia patients in ACT and dementia patients in Australia. In ACT, always above the average with dementia patients living in the ACT. All the people in hospital in Australia, I just would like to concentrate on 30% of patients in acute care have cognitive impairment. It just can highlight to you how many patients we actually have admitted here in hospitals with cognitive impairment. And I just would like to say how important that we know how to deal with this patients and how we need to actually acknowledge that we have that many patients with cognitive impairment. BPSD is behavioral and we tend to think that behavioral and psychological symptoms of dementia are actually behavioral expression of unmet needs. And when we say that, it's actually will reverse our thinking probably a little bit, because we used to think, okay, if this patient comes to us and we need actually to do what we think comfortable, what we think normal for us, but no, it's actually opposite. We need to go with patient and see what we would like, what patient actually needs, what needs he has. And it can be from constipation to hunger to pain, and these things need to be addressed, and or just he's not uncomfortable because he just wants to wander, walk, eat, drink, or other really simple things that we can do.
So what the aim of the project was is the team came to me and they were looking for some support from the Synergy Research Centre to better understand how they could support their staff to look after people with behavioural and psychological symptoms of dementia. And that sounded like a fantastic idea, and to be looking at the education, perhaps the nursing and medical teams about how they engage and make decisions for people with BPSD. But when I asked what I thought was an important but fairly basic question was, how many people with BPSD do you have? They couldn't tell me. And so we reframed some of that project to really try and get some better data that we would be able to then also report on, not just for the unit level, but also for the whole hospital level. So we were looking at rates of admissions for people with dementia, both to the ward and also to the whole hospital. We wanted to understand what were their primary diagnoses and what were potential complications. So you can use primary and secondary diagnosis from hospital discharge data sets to understand potentially preventable complications. And that can then be an indicator of how well we're doing care, of what kind of quality nursing care we're providing. We wanted to look at, and one way of trying to pick up the patients with BPSD is using the assessment tool that they use for their special care unit, so we were going to look at that data. We wanted to have an understanding about the extreme end of the spectrum where they were needing to call code blacks to get security guards to come and help people, which, as you can imagine, is not your favourite way of treating somebody who is so uncomfortable with their hospital admission that they are flailing about and lurching at others, but obviously we have to protect the other people who are in the hospital as well. We wanted to look at a staff survey to better understand what their education kind of current levels and needs were, and actually look at what the staff training, current existent training was. So one of the things that we were looking at were these complications that I was talking about. And so these are 4 commonly occurring complications for older people in hospital. that are potentially preventable, and you can use hospital discharge data to better understand those. And this is just recognising that because we're so focused often on patient flow, that we tend to limit and prioritise care to the more life-threatening and acute needs, and we might actually be deprioritising basic healthcare needs and what is known as fundamental or essential cares. And so what did we find? People with dementia in the hospital, these rates are about 800 in 2008 in the whole of hospital, and you can see the top line's the whole hospital and the bottom two lines are in geriatrics and the 11A ward specifically. So you can see here that people with dementia are all over the hospital. They're not just going to be in the aged care ward. And that's always going to be the case. There's lots of discussions about what's the best place to put people with dementia, but given that 50% of people in the hospital are over the age of 65, they are always going to be all over the place. Aged care ward isn't necessarily where they need to recover from their surgery or have their medical treatment. These numbers I actually think are quite low. On average, there's about 10% should be, and these are actually only about 1%. So I suspect that some of the coding might not be fully documented, and we do know that capturing dementia in documentation is poor. The big jump that you can see in 2016, I suspect, is that that's when the National Framework for Dementia came out, and there were some incentivisations potentially for cost adjustments for complexity if dementia was included in the coding, but I'm yet to discuss that with clinical records. This is just having a look at the different rates, and so you can see that delirium heads up to about 8% in 2014. Agitation, which might be a good way of actually coding BPSD in the hospital population, isn't really used. It doesn't seem to either get, I'm sure it gets written by nurses that patients are agitated or pleasantly confused, but it doesn't seem to be making it into the coding records, and this might be something that we can be discussing. The secondary diagnoses, and so these are what I would call potentially preventable complications that are sensitive to nursing care. You can see there's quite high rates of delirium, up to 30%, that the UTIs are often quite high as well. Pressure injuries less so, and pneumonia less so as well. Interestingly, the pressure injuries, while we were able to pick them up in the coding, we didn't necessarily have the pressure injuries being picked up in the incident reporting. You can see the big decrease that starts happening after about 2015, and that is when this whole hospital had a whole of education approach for the Dementia Care in Hospitals program. This is a whole of hospital approach, looks at educating ward assistants as well as wardsmen and ward clerks as well as nurses and doctors. This was trialled on 5 different wards and has a cognitive impairment identifier, so like a falls risk sticker sitting on the top of the bed to say this person has some kind of cognitive impairment, so please communicate differently and be cognizant of what their needs might be. So it does look like there's a definite trend downwards. Again?
Yes, this is the example of our current admission criteria to geriatric special care unit, which has 5 beds for dementia-specific BPSD patients. And as you can see, the majority of our patients are admitted with high falls risk, agitation, and restlessness. 23.1% will be admitted with physical aggression, but it's probably what our staff will report is on this patient. That's what they will remember, the patient that admitted with physical aggression. This is the new suggested admission criteria. We thought the previous one didn't give us an indication actually into patient's behavior as displayed in nursing home or home. We based our new admission criteria on Cohen-Mansfield inventory scale, which is actually as you can see, it breaks down the behaviors from kicking, pushing, hitting, throwing things, and to physical aggression. We have conducted a staff survey, level of confidence and training at ASO Board 11A, and as you can see, the staff feels less confident, 14.3%, caring for patients with BPSD, and a bit more confident caring with patient with dementia. 21% of our staff has completed staff PAT training, which is just to remind you, the PAT training is designed actually for mental health, not really for dementia or BPSD. These are comments on challenges that our staff experience, and majority of comments, of course, they are on physical aggression towards staff and from patients.
And obviously the kind of comments that staff talk about that actually help with people with cognitive impairment is knowing the patient's history and staying calm and using skills learned from education experience. And training courses, which really brings us to some of our limitations, is that the PART training we mentioned, because that's the only course that was accessible for any kind of cognitive impairment training. PART is for physical escalation response in mental health, and that is really inappropriate when we're talking about 30% of the population who have a cognitive impairment. We need to be able to recognise and identify dementia and delirium and prevent the medical emergency that is delirium. But there's actually no training available across the hospital for dementia, cognitive impairment, assessment, screening, or anything like that. So we do hope that that might change in the future, and that we might be able to get better data about code blacks, because obviously this is about security and safety of staff as well. So we've got some improvements in admission criteria, we've got better ways of collecting data, and we are looking at improving the training access to PART, as well as other kinds of cognitive impairment training that I know are on the cards in the system. So there are our references, and we're happy to stay a couple of questions if there's time. Thank you.
Thank you. That was really, really interesting. I'm sorry we haven't got time for questions because we're 20 minutes behind already. So if you get a chance, please do follow up with the speakers in the break. We have one last presentation for them before Carolyn Homer will be speaking. Is he here? We've got Rory Maguire talking about access to quality end of life, palliative care in the prison setting. So we're happy to have you here today. I understand you got locked up yesterday.
Yes.
Okay, we'll need to be quick. Thank you.
Thank you for having me. My name's Rory. I'm the Assistant Director of Nursing for Custodial Health. I was meant to present yesterday, but the jail went into lockdown, so I actually wasn't able to get here. So I think I get an award for best reason for not coming. But it does illustrate rather beautifully the reason, or some of the challenges that we face in delivering healthcare in a custodial environment. So I work for Justice Health Services. We're the JH in the Mental Health Division. We work across a number of settings, so custodial, inpatients, community and courts. I manage the primary healthcare teams at AMC and at Bimbri, which is our youth justice centre. We provide a comprehensive primary health service to adults and young people in custody in the ACT. We have doctors clinics 5 days a week, nursing staff and mental health staff 7 day a week. We provide dental services on site, drug and alcohol nursing services, population health services, and any of the sort of more specialist type services are provided here at Canberra Hospital, so things like radiology, pathology, surgical, inpatient, those sorts of things. So we access services in the community as well. The AMC is a 500-bed facility. It's located in Hume. It's on the Monero Highway. Many of you have probably driven past it. It's a small to medium-sized prison. It's not a particularly large facility by prison standards, but it's owned and it's managed by ACT Corrective Services. Hume Health Centre is a community health centre run by Canberra Health Services, which is located in the walls of the AMC. And the reason I put that in there is because we are a community service. We're not an inpatient service. We don't have any inpatient beds. Everything we do, I always talk about us being a hybrid between a community health centre, a walk-in centre and an emergency department. We sit somewhere in the middle. Our detainees live in a variety of accommodations, so there's your typical kind of cell blocks that you would expect to see on television, but we also have accommodation areas which are more like cottage, communal type living as well. They access health services at the Hume Health Centre, but we also have satellite clinics dotted around the jail. And our nursing staff do medication rounds 3 times a day, so they're able to access healthcare provision through that. This data comes from the Australian Institute of Health and Welfare. They provide a Health of Australia's Prisoners study every few years. What it basically shows is our patients come from really challenging backgrounds with high burdens of disease. We have a lot of mental health issues, lots of self-harm. 3 in 4 are smokers. That rate has dropped, and that's low, and that's partly because we've banned smoking in some jurisdictions, and this is national data. That hasn't yet happened in the ACT. Lots of people use drugs, low educational attainment, lots of physical health conditions, and really for us it's about when you start looking at healthcare from a social determinants kind of perspective, we're really quite starting at quite a low bar. Interestingly, and in relation to this, 3 in 4 deaths in custody were due to natural causes over the reporting period, which I think was about 2016. So our patients are disadvantaged. There's poor health literacy. Many of them don't utilise health services in the community, and it's when they come to us that they start to go, oh, I'm actually going to get that checked out. Most of them will return to the community, and only a really tiny number are actually going to stay in jail for the end of their life. I think in the ACT we've got about half a dozen who we would expect, simply by the length of their sentence, to be in jail, but to die in jail. We're also seeing, like the rest of the community, an ageing population. That's partly because the population in general is growing older, but also after the Royal Commission into Institutional Child Abuse, we saw a lot of people coming into jail convicted of historical offences. So we decided that we were going to do that really, really unusual thing by health standards and pre-plan for this. So we've got very small numbers, but the opportunity arose to take a really collaborative approach with ourselves, with our partners in corrective services, Clare Holland House, Woononga, the Advanced Care Planning team and AMBOs, to really kind of look at what does a pathway look like for people who are in jail and who are coming towards the end of their life and require palliative care. What we did was recognise that end-of-life care is a human right. We are a human rights compliant prison. And so what we started to do was look at the literature elsewhere. Custodial healthcare literature is limited, and each particular setting and each jurisdiction has its own unique challenges and dynamics which make translating what one place does very different. A lot of the literature comes out of the US because they have a massive prison population. Thanks. And so we took we looked at what they were doing, but we don't have a hospital ward. We don't have 24-hour nursing care. So then what we started to do was look at our case studies over the last few years and put a bit of a framework around that. We looked at the legislation. There are legislation differences, obviously, between Territory and Commonwealth. We hold detainees from both who are convicted under both types of law. So that has impacts on how we manage. Some of our key considerations were the patients themselves and what they want. Their family members, both people, their family members in jail and in the community, other detainees in the centre and what that looks like, and staff, and the impact that someone at end of life in jail has. The complexities of the custodial environment are, it's a jail. It's not a hospital. We don't own the facility. Corrections owns the facility. I can't access a patient if they don't unlock a cell for me, is the long and short of it. Or I can't come and present at a conference if they say no. The model looks at a few things. Compassionate release is a particular process which is legal. We can assist with that process. The success rate is pretty low. It's about 2% in Australia for a variety of factors. But really for us it was about taking a healthcare approach and looking at what palliative care should look like, and we talk about the equivalent healthcare in what happens in the community. So looking at it from a holistic perspective, being very aware of the environment that people are in, taking a trauma-informed approach, particularly because we have so many Aboriginal and Torres Strait Islander people in jail. Looking at staff support and education, and then also bereavement for other people who are left behind. Evaluation, we only have had a limited number of people who've died while they've been in custody, so we've looked at, there are case-by-case differences. Our next step is kind of to look at doing some consumer engagement with our detainees and putting this model to them and engaging them in that process about what they expect and what they're looking for, and also seeking input from family and staff. This was the project team. It comes from all across Canberra Health Services and various directorates, and it's been pretty awesome. There's a reference because I'm doing a presentation, and thank you very much.
Thank you, Rory. And I'm sorry we haven't got any time for questions again, but we would love to hear about the evaluation next year. So now I'm going to hand over. First of all, thank all the speakers. That was a really great session. And hand over to Karen, who's going to introduce our key speaker.
So it's my pleasure to welcome our keynote speaker, Professor Caroline Homer. Caroline is the co-programme director for maternal and child health and co-working group head Global Women's and Newborns Health at the Burnet Institute in Melbourne. She's a distinguished professor of midwifery at UTS. Caroline's been involved in the development and evaluation of midwifery and maternal and newborn services in Australia over a number of years, and in a number of other countries in the Asia-Pacific region, including Papua New Guinea, Samoa, Cambodia and Timor. Since 2008, she's been co-chair of the Expert Advisory Executive for the development of national antenatal guidelines for the Australian Government's Department of Health, and is a member of the WHO's Executive Guidelines Steering Committee and the WHO Maternal and Perinatal Health Guidelines. So a very warm welcome to Caroline.
Thank you very much, and thank you for the invitation and to come down to Canberra today. It was a bit of a shock at -2, I must say, when I got out of the plane, but as a new recruit to Melbourne, I'm used to the cold, but I'm not enjoying the grey. So to come out of the plane in your beautiful skies this morning was just lovely. I'm going to start by acknowledging we're on Ngunnawal land and pay respects to traditional owners past, present, emerging, and because I'm a midwife, the future. And I think we're very fortunate in Australia to have such an extraordinary Indigenous heritage, 3,000 generations. So when I think about being a midwife, and maybe in this part of my career seeing the second generation of babies I've been involved in, to have a heritage of 3,000 generations is pretty extraordinary. So today I'm going to talk about maternal health, and I'm going to focus on midwifery care, midwifery continuity of care, and of course the best midwifery care is as part of an integrated and organised system. And that includes all the colleagues in the health system, and many of you are here today, and I will touch on the different roles that different players have in the care of women. The maternal health is obviously around pregnancy, childbirth, the postpartum period, and sometimes we try and include preconceptual health, but we're not very good in Australia at bunching that up together. So Australia has a pretty good healthcare system. As the introduction said, I work in Papua New Guinea quite a lot, which is like being on another planet in terms of the health system. So it's lovely to come and walk around Canberra maternity unit this morning and see what a beautiful facility that you have here. We have, in 2017, actually 302,000 babies were born in this state. In this territory, there are about 5,000 births a year, so you account for just under 2% of the national births. We have a maternal mortality rate which is around 8 per 100,000 live births. It goes up and down a little bit each year because it's accounting for about 30 deaths a year, which is a small number in comparison to the large number of babies born. But clearly every maternal death is a tip of the iceberg of all the bad things that could go wrong in maternity care. In our neighbours, in PNG, the MMR rate, maternal mortality rate is, we don't really know, but it's somewhere between 500 and 700 per 100,000 live births. So an hour north of Cairns, it's a very different story. Neonatal mortality has been reasonably low over the years. It's about 7 per 1,000 births. It's reduced in recent years, which is very encouraging, and there's some very good work obviously going on preventing preterm births, which is one of the largest killers of newborn babies, but also in the care of newborn babies once they're born. Unfortunately, stillbirth rates have remained remarkably constant over the last 20 years. They're at about 2.6 per 1,000 in Australia. We're not up there with OECD countries in terms of stillbirth rates. We're higher than we should be, given our current system. And there is a big initiative going on at the moment on stillbirth around the country, kicked off by the Senate inquiry for stillbirth, which produced its report early this year. That was pushed by Christina Keneally in her new role as Senator. So there's a lot of good things happening to prevent stillbirth, or reduce preventable stillbirth, and I know hospitals in this territory are part of those initiatives. Caesarean section rate is a tricky one. whether we use it as a quality indicator or not. The current caesarean section rate in Australia is about 35%. There is WHO evidence that once you get over about 20%, it doesn't make a lot of difference to your other indicators. But when I started my midwifery training in 1989, the caesarean section rate was 18%. So in my career, it's doubled, which I'm not sure many other interventions would have gone that quickly in a space of 30 years. So I'm going to come back to caesarean section rate because it is an important driver of healthcare costs. It's obviously a life-saving intervention for both mothers and babies, but perhaps we're not using it for the right women at the right time. There is a movement around the world looking at too high caesarean section rates and too low caesarean section rates. PNG, as I mentioned earlier, has a lot of problems. It also has a caesarean section rate of less than 5%, which is too low. And there are mothers and babies dying because they're not getting access to caesarean sections. So somehow we need to work out how to import some caesarean sections to other places. And huge gaps still exist for Aboriginal and Torres Strait Islander women across the country. About 1 in 22 births in Australia is to an Aboriginal or Torres Strait Islander woman, equating to about 1 in 18 of the babies are Aboriginal or Torres Strait Islander heritage. So it's a considerable number of babies and women. We still see big disparities in preterm birth rate, in stillbirth, neonatal mortality, and a 4 to 5 times difference in maternal mortality, even though those numbers are still very small. Again, there's some fantastic initiatives going on around the country, particularly a program called Birthing on Country, which I'll come back to, which is not necessarily giving birth on country, but it's a concept around cultural safety for Aboriginal and Torres Strait Islander women, which is showing very encouraging changes. So we've got a lot to be proud of in Australia and a lot still to do probably. So why does it matter? Childbirth has long, medium and short-term consequences. There are things that we see as clinicians in hospital, things that happen in our labour wards, in our neonatal units, in our postnatal wards. But we see women in clinical practice for a very short space of time. Then they go out into the world. For child and family health nurses, for obstetricians, for community paediatricians, for gynecologists, they're seeing women and babies for a longer period of time. But health is still a very small microcosm of all the other things happening in people's lives. There are implications on this pregnancy, obviously, if the baby's born early, if the baby's born sick, if the mother's unwell, if something happens, emotionally, psychologically and socially. The baby may be born well or not well. There's time in a nursery, very disruptive for families to have a baby in a nursery, particularly if they've got other children at home. And you would see that in this hospital a lot with women coming from outside, from the regions. So it's not that they live next door. They might live in a country town some hundreds of miles away, depending on where a neonatal bed was available. So women have very different postnatal journeys, mostly very good, but we are seeing signs of trauma in some women, and that might be physical trauma or emotional trauma. And this feeds into motherhood and fatherhood. We want women to give birth, be as strong, confident mothers, because they're going to be better mothers if they feel strong and confident for their families. And so our job should be around making sure that happens. Clearly, depending on what happens in this pregnancy makes a difference to your next pregnancy. And that can be a positive experience or a negative experience. And when we see stories of women who choose to go outside the system for the next pregnancy, and we sometimes disapprove of that they might have done that to have their baby, often it's because of something that happened in the last pregnancy. Something that happened in the hospital that we might have seen as totally routine and normal, but wasn't interpreted that way by the woman. And so we have to think about what we're doing in the next pregnancy. And of course on ongoing women's health, particularly issues relating to 3rd and 4th degree perineal tears, and again there's a lot of interest and work around that at the moment. All these things impact on families. You know, women don't have babies just in a little vacuum or in a little bubble. They go out and join the community. They go back to work. They go back to being part of society. And so childbirth makes a difference. It also is expensive. It's one of the Most common reasons for admission to hospital in the country, having a baby. 300,000 admissions essentially each year. That is a lot of healthcare costs. So if you can think of the caesarean section rate doubling in my career, that's a big difference in theatre costs over that time period, just as one example. So it matters to all of us. And we work in health, we want to provide quality care. We all come to work wanting to provide quality care. And the more quality care we can provide, the better we can make the experience for mothers and their babies and their families. So I strongly believe that all health systems want to provide quality care. But we see poor quality care in all countries. These days I mostly work in poor countries, in low to middle income countries, where there's plenty of examples of poor quality care, unfortunately. But I know it happens in high income countries too. I know it happens in all the hospitals in the country for all sorts of reasons. And in recent years, we've divided up maternal care into two concepts. One is too little, too late. So that's care that's not timely and not sufficient. And we see that mostly in low to middle income countries. But we're also seeing too much too soon. And this is a concept of over-medicalised care and the use of unnecessary interventions. Perhaps we could have sitted and waited for a bit longer, but we jumped in and did something. And often women either receive no care at all, and fortunately that doesn't happen very often in Australia if we provide access to the right care, or women feel that the care on offer is not acceptable, and so they go elsewhere. Or they're not compliant, in inverted commas. And we get cross with that. So the Lancet's Maternal Health series in 2016 looked at this concept of too little, too late, too much, too soon. And this is the list that they came up with. It's rather a simplistic list, but for the purposes of this morning, I'm just going to take you through mostly the too much, too soon. Too little, too late, we see a little bit in Australia. We have national antenatal guidelines. We don't have national intrapartum guidelines or postnatal care guidelines. So we are missing big bits about what we could be doing nationally. Rarely we lack supplies and equipment. Rarely we lack inadequate numbers of skilled providers, although you could probably argue that based on how busy your labour wards are or your maternity units are. And we are seeing a shift in the demographics of women coming back into the public system to have their babies, and that's going to change things in many of your hospitals. Fortunately, we don't see women giving birth alone very much, and we do have access to emergency services, although you probably see some of the lack of access as women are being brought into the Canberra region from the rural areas. In high-income countries, it's more of the too much too soon. So too many unnecessary caesarean sections, too much induction of labour, too much monitoring, too much episiotomy, and too many antibiotics. These are all very tempting things to use. They're interventions that we've developed. We know used wisely, they all save lives. Used unwisely, they add to this too much too soon concept. So the ones that we mostly focus on in high-income countries, as I said, too much electronic fetal monitoring. That doesn't look like a comfortable way to be in labour for 12 hours and have a baby as an active birth. And there is no good evidence that routinely screening women with an electronic fetal monitor who are completely well and healthy makes any difference. But it's a machine, it's by a bed, we're so tempted to use it. And then it's really hard to take it off because we kind of get sucked into having it on. Caesarean section, as I said, is a life-saving intervention for mothers and babies. But is 35% across a country the right number? Is it too many? We need to look hard at that. And again, induction of labour. At the moment, our induction of labour rates in Australia are 33%. So 1 in 3 women are induced. Again, many of those are useful and important, but I'm kind of astonished that a third of women need to be induced now in Australia. That's just a phenomenal amount of women. Routine episiotomy, when I started training, we did these on everybody, and it's gone out of fashion. It's coming back into fashion a little bit at the moment on a selective basis. And again, we are concerned about 3rd and 4th degree perineal tears. And so selective episiotomy is having a renewed resurgence. and we need to work out from good evaluations and research if that's a good thing or not. And globally, we have an antibiotic microbial resistance problem. We throw antibiotics somewhat enthusiastically around everywhere. And it is a big issue around, is that causing resistance? Is that contributing to longer term problems? So as I said, in Australia, the rates have trickled up. And I didn't go back as far as 1989, but we continue to go up. We're actually over this number in 2017. The data were just released last week. And again, induction of labour rates are going up. Not extremely high perhaps, but still enough percentage points that maybe we should be concerned. This is data from the Australian Commission for Safety and Quality in Healthcare. That's their second atlas. Each year, the last 3 years, they've released what they call the Atlas of Healthcare Variation. Maternity care appeared in the second one for the first time. In this, they looked at caesarean section and 3rd and 4th degree perineal tears. This is age standardised rates per 1,000, and it's where women live, not where they have their babies. So this is statistical area level 3. And they tried to have the same sort of women. Of course, they're not going to be the same, but they're the same age. And selected is trying to pull out, so having one baby, having a head-down baby in the same age rate, and I think this is having the first baby. But the different colours, the lighter the colour, the lower the rate. So you can see even in this part of the world, the southeastern part of Australia, the rates vary significantly across the regions. And, you know, you'd have to ask why. Is that women are different from this area to this area? Or are the clinicians different? Or are the hospitals different? Or are the policies different? And maybe some variation's okay, but maybe we should question variation a little bit more. It's interesting, in the big cities, the variation is a bit lower, whereas you'd almost think it should be the other way around. So I think it's important for us to look at variation more. This is across the country, and that the areas are bigger, blocked up, so not at a higher gradient. But again, you know, some areas are very high. The numbers obviously in these sort of areas are smaller, but you know, geographically, maybe the same number of women kind of live in this area than in this area, but the colours are very different. The variation across the country is quite extraordinary. So again, is it different women? Is it different clinicians? Is it different providers? Is it different ways of looking at the world? And how much variation is okay? What we've seen in the last couple of decades is that caesarean section and induction of labour is shifting the mean gestational age to the left. So we're getting earlier. So this is an extraordinary kind of evolutionary thing happening in our lifetime, which actually isn't normal, obviously. But we should be concerned about it, because does this mean there are other things going on, the unintended consequences of us having babies born more early? So this is data from Jonathan Morris's group at the University of Sydney, and you can see the different colours. So this is the pinker colours are 2009, and and this is 1994. So you can see the weeks of gestation has come down quite significantly, and it's shifted. So the peak is more over here, which is at 39 weeks, compared to the peak at there, which is just over 40 weeks. So maybe a week doesn't make any difference. Maybe a week at a population-based level doesn't make any difference. But I find this really interesting, that at a population level, we are shifting when babies are born. And Charles Darwin would be kind of astonished, I think, that we've managed to do it from 1994 to today. When we look at spontaneous onset of labour, we don't see the shift. So this is spontaneous onset of labour. The numbers are going down. This is the older time period, 1994. This is most recent. The proportion's going down because there's just less women going into spontaneous labour. That's for that reason. But these curves look very different. So this is induction, and again, the shift is to the left. The shift is getting earlier, and this is pre-labour caesarean section, and again, the shift is moving to the left. So in only 20, 30-year period, big changes, I think, in when babies are being born. And yeah, maybe a week doesn't make a difference, but maybe a week does. So this is 2006 to 2016 in a 10-year period, and you can see the darker colour is 2006. So as we go up, more babies are being born at about 39 weeks than they were in 2006. So in 2006, most of them were at 40 weeks. 2016, most of them are at 39 weeks. So whatever way you look at it, we have shifted. And so the Commission for Safety and Quality in the most recent atlas released earlier this year is concerned about early planned caesarean section without medical or obstetric indication. And this is a little bit woolly because it's hard to sometimes unpick what is medical or obstetric intervention. But across the country, and again in terms of variation, it ranges from 42 to 60% of the planned caesarean sections at 39 weeks not having an obstetric or a medical indication. And again, at 37 weeks, so for those of you who are not in maternity care, the definition of term is from 37 weeks on. So these babies are on the edge of being not being term. These are preterm babies, less than. And again, there's differences between publicly insured and privately insured women, which we've seen for decades and continues. So there are concerns, not only in our country, but across the US and in the UK, about this early planned caesarean section without medical indication. And a lot of emphasis now on waiting if your baby's well, if you're well. We're balancing that up at the moment with the issues of stillbirth, because on one side we don't want to raise the caesarean section rate unnecessarily, but on the other way we're trying to bring the stillbirth rate down. So it is a very difficult balancing act, I think, that we're in at the moment, trying not to create unintentional harm, but trying to also ensure that mothers and babies are born safely. So there's an alliance established called the Australian Preterm Birth Alliance, Prevention Alliance, and this is specifically looking at preterm birth. It comes out of, was established by John Newnham in Western Australia, and now many clinicians across the country are part of that, and I'm pretty sure both of your hospitals are. And this is just their statement, starting to be concerned about elective birth before 39 weeks. As we know that that sort of time period is now associated with important consequences in later life. So this is behavioural and learning problems even at school age. And so what the group in New South Wales have done, Jonathan Morris's group, is actually link data, perinatal data with NAPLAN data, and showed that once you start controlling for problems that we know should result in longer term problems, this issue of caesarean section or being born around 39 weeks has long-term issues. So maybe that week does make a difference, the 40 weeks down to the 39 weeks. So we need to think about the way we provide care. And for the most part, we provide excellent care. We provide care that is safe and of quality. But we have strong consumer movements around Australia that are not always convinced about this. And this is the largest consumer organisation for maternity care, Maternity Choices Australia. And they are running a very big campaign at the moment about better options for pregnant women. So we need to work closer with our consumer groups to make sure that the care we are providing meets their needs. These are the three main issues that they are calling for at the moment. Continuity of midwifery care, a change to the way funding is provided, particularly to hospitals to provide maternity care. Hospitals are very acute focused, as they should be. Maternity care could be or should be more primary healthcare focused, more in the community. The funding models don't really let that happen, and those of you who are managers in the room know too well how difficult this is to traverse the funding mechanisms that we have. We also have the funding shift, obviously, between state and federal systems. And professional indemnity, which is a hot topic, which I'm actually not going to talk about, but just to say it's women who give birth with a privately practicing midwife at the moment don't have access to professional indemnity insurance, or their midwives don't have access. And there's an exemption at the moment that allows that to still happen. But it's been in place for a long time, and we've still got another 2 years to go of the exemption to try and solve this very messy problem. So this is a campaign that Maternity Choices are doing at the moment. So just to show you that it's not all happy out there. There are some unhappy players. And this survey, I took this down on the weekend, 30,000 people have signed this petition wanting better options for women. And mostly this is access to better, those three issues I mentioned: continuity, professional indemnity insurance for their midwives, and I've forgotten the last one. Reform. So we need to engage with this, as well as thinking we're doing a good job. For the most part, we are doing a good job, but we need to still think about, what does our community want? What do our consumers want? How do we better work with consumers to make sure that we deliver the services that they need and want? So I've been working in this space for a long time, mostly trying to focus on reform, trying to focus on how do we bring about widespread change in the way the maternity services are delivered. In many places, we're still delivering services like we did in 1989 when I did my training. Acute care focused, big hospital focused, very fragmented, a bit impersonal, and not very woman-centred. Fortunately, the world is changing, but it's taking a long time. This was a report. This is the first task force report done, statewide task force report, and it happened in New South Wales in 1989. It was released, and it's called the Shearman Report, lovingly, because Rodney Shearman was the chair. He was an obstetrician in New South Wales at the time and was the chair of the report. It was done in the time when the report was written on a typewriter. I have copies, and I've actually had to scan each page to have an electronic copy. But you know, that's the kind of context we were in back then. This is his quote, which I'm still very fond of. And of all life choices, none is more important to society, none has more far-reaching consequences, none represents a more complex blending of social, biological and emotional forces than bringing another life into the world. And that was a quote from 30 years ago, and I think it's still absolutely relevant today. And I always challenge people who work in maternity units that for us it's, you know, you've got 15 or 20 beds in your labour wards, it's very busy, you're rushing into this room and that room. She's one of 6 women you've seen today, or in an antenatal clinic, she's one of 35 you've seen today. But for that woman, it's the only time she's having this baby. This is the only experience for her with this baby. And so it's a critical moment for her that we have the opportunity as clinicians to make a difference, even in that tiny moment in an antenatal clinic. So 30 years of reports, and there's actually another whole page of them, but I got tired of making the font smaller to fit them all in. We have bucket loads of reports that say, we're doing an okay job, and in some places we're doing an excellent job, but we still have things we should be doing better. And for the most part, continuity of care is the common theme through all of these reports. And it's not rocket science. We actually all like continuity in our lives. I go to the same coffee shop every morning because I don't have to order my coffee, it just arrives. I go to the same GP because they know me and I don't have to tell my story again. I'm sure you all have many examples of continuity in your lives. You park in the same place in the car park every day, so you remember how to get back to your car after a long shift. These are not hard things. Why wouldn't women doing that most important thing, giving birth to a new baby, want continuity? Why would they think it was okay to have strangers wandering in any moment of the day or night? So then we've got the reports, and then over the last 25 years, we've got some research around midwifery continuity of care. And I'm actually going to run through the biggest trials very quickly because just to show you there is now bucket loads of research for this model of care. And doing health services research is also quite hard. It's organisational change. It's difficult. You have to wrangle all the staff and wrangle the managers and wrangle the economists in your service, and then you have to rearrange how everything works. So all of these studies were hard to do, and that's why they're kind of even more impressive. So this is the first one from 1985. This is Know Your Midwife Scheme, and from the UK, and it was the very first study, only in 500 women. These are all the randomised control trials. Then we started in Australia, 1995. Of all the trials of midwifery continuity of care, half of them come from Australia. So when people say to me, oh, we won't listen to that research, it's all done elsewhere, is actually nonsense. Half of them are done here in this country. This is Marilyn Ferrer, Marilyn Rowley at that time, 1995, done at the John Hunter Hospital in Newcastle. And a bit of a larger trial. There was 1,000 women in this trial. Then we've got a trial from Canada, which was a smaller trial in 100 women. These are all starting to say the same thing. The first one said women like continuity of care. The second one said they've got good outcomes, less intervention, women really like it. Again, this one, the caesarean section rate, this is the first trial to show the caesarean section rate went down with continuity of care. This is a trial from Scotland. We're now up to 1996. This was published in The Lancet, and it comes from colleagues who are now in South Australia, but the trial was undertaken in Scotland. And again, a bit bigger, and now 1,300 women. Then in Victoria, we've got a number of trials. This was the earliest one from Marianne Biro at the at Monash Medical Centre, I should say. Again, really good clinical outcomes, less intervention, good outcomes for mothers and babies, and women were very satisfied. This is the satisfaction paper that went alongside this. This is 2000. This is the study that was originally my PhD. We published it in 2001 at St George Hospital in New South Wales. This was a collaboration trial, the first time that women with high risks and low risks were included. The previous trials were all low risk healthy women. This trial was all comers. So we worked very closely with obstetricians in the community. The antenatal care happened in community-based centres, not in the hospital. We took obstetricians out to the community with us once a week to see women in the community. They came into hospital when they needed. This showed a reduction in caesarean section rate and all the other same outcomes as I've mentioned before. Then we jump forward a few years to 2012, and this is Cosmos, which is caseload midwifery from Victoria. This is bringing the teams of midwives down from about 8 midwives looking after a group of women now to 3 to 4 midwives looking after a group of women. So when you had to meet 8 midwives, probably the continuity wasn't really fantastic. When you only meet 3 or 4, you start to know your midwife. You start to know who they are. You start to know what they start to know you. You start to get that relationship. So this trial, published in the British Journal of ONG in 2012, started to show real benefits around this smaller group of midwives, smaller number of women. And then Sally Tracy's paper, which was done in Sydney and in Brisbane, published in The Lancet in 2013, again showing the same thing. These are big public hospitals, caseload midwifery, so 3 to 4 midwives, each caring for about 40 women a year. And so you can add up the maths to how many a year. This trial has also had a number of cost-effectiveness studies attached to it, which I won't present here, but all showing good cost-effectiveness. And this is the most recent paper published only a month or so ago, looking at the women's experiences from that last trial I just showed you, Mango. And again, very positive experiences. So we've now got positive physical experiences, outcomes, cost outcomes, and women's experiences are all kind of lining up to make sense. So there's a Cochrane systematic review of all of these trials. This review now includes 15 studies. There are 17,000 women in this review. And they're all of those studies that I've just shown you and some others. There are also bucket loads of cohort studies, of qualitative studies, of observational studies. There is a very, very enormous body of literature around this way of delivering care. This is the findings from the Cochrane Review. Unsurprisingly, women are more likely to know their midwife at their birth, so they're not having the stranger walk in when they're in labour. They're less likely to lose their baby, either early or before 24 weeks, less likely to need analgesia, I'll come back to this one, less likely to have an episiotomy. This one is a really important one, 24% less likely to have a preterm birth. This is a very significant intervention that we can make a difference to preterm birth. We have other things we can also add into the mix here. And there are other interventions that are being used, I know, in this hospital. But preterm birth rates have been remarkably stable over the last decade. And now we have an intervention that could make a difference. More recently, I and a group of colleagues from the UK looked at midwifery continuity of care in a poor area in London. So many of these models have been in kind of, maybe not rich women, but reasonably well-established, perhaps on the upper end of the socio-economics spectrum. We looked at this data in the Albany midwifery practice in a very poor part of southeast London, where midwives had been providing continuity of care for a very long time. These women were a high number of women from Black, Asian and minority ethnic communities. A third of them were single. 1 in 10 had no support, and many lived in council housing. These were poor women who didn't think they deserved good care, and many of them were quite shocked when they got midwifery continuity of care. They ran the service from the sports centre in the community next to the swimming pool. So women went and did their swimming and then came and had their antenatal care and had their groups, and they had the babies at King's College London. Lots of good outcomes, high rates of continuity of care, preterm birth rate, which for this population is very low, all very positive, and increasingly 44% of women had a home birth. These are women who said, I could never have a home birth, I don't even have a proper bathroom. I live in a council flat that's poor. But these midwives stayed with women in labour and made the decision about where the baby was going to be born in labour. They didn't make it before. They said, we'll come to you in labour, let's see what happens. And for just under half, they stayed at home. A very low caesarean section rate. And the UK has pretty terrible breastfeeding rates. So 92% initiation breastfeeding was pretty extraordinary. And very positive neonatal outcomes, particularly given the disadvantage that these women had. So a 6 per thousand perinatal mortality rate with no intrapartum uterine deaths. So I mentioned before that we have some exciting initiatives around the country for Aboriginal and Torres Strait Islander women. And this paper was just published from colleagues in Queensland, Sue Kildea, in eClinical Medicine, which is published by The Lancet, showing that a continuity of care model, a new model where women saw the same midwives through and through the model, a system that was designed, owned and activated by the Indigenous community. So it's based in an Aboriginal community-controlled organisation, supported by the organisation, and then the midwives from the Mater Hospital came in, provided midwifery continuity of care, 2 to 3 midwives for a group of women, and showed about a 50% decrease in preterm birth. So this is one of the big closing the gaps we need to sort, preterm birth for Aboriginal and Torres Strait Islander women. And when they did all the controlling, you can see the odds ratio is 0.57, so almost 50% reduction in preterm birth. This is not a randomised controlled trial. This was a matched cohort study, so there's some challenges around the science, but this is highly encouraging associations that we need to keep working on. And so then there's the question of why does continuity make a difference? What is the mechanism? For those of you who are scientists and into mechanisms, what is going on with continuity of care and preterm birth or the other interventions? And the hypothesis at the moment is around stress. So when we're around caregivers we know, when we're around people we know and who worry about us and care for us and we think they know us and we know them, we have less stress. And I guess you can think about that in your own lives in terms of what mediates stress. So this hypothesis was tested in a really interesting study that's come out of Queensland called the Queensland Flood Study. You may remember in January 2011, the Brisbane River went up, and many, many people along the banks of the river or even in low-lying parts in Brisbane had their houses inundated, and significant amount of stress for those families. So what Sue Kildare and her colleagues were able to do was look at women who were having normal care, so standard, pretty fragmented care, maybe saw 5, 6, 7, 8 midwives and doctors antenatally, many different midwives and doctors intrapartum, many different midwives and doctors postpartum, so, you know, up to 30 caregivers, with this midwifery continuity of care model, because we were running the Mango study at the time, the continuity of care model. So compare the 30-odd caregivers with potentially 3 midwives and doctors as needed. And they showed, it's only in a small study unfortunately, but there was decreased depression scores with increasing objective and subjective stress. So even though women were stressed, their depression scores were lower if they were having continuity. And this is now being replicated in Canada, where they've also got some big climate change kind of studies looking at ice storms and the effect of stress when you're in an ice storm. And can you mediate that by the model of care that families are in? So a hypothesis testing study, but still very interesting. I mentioned the Preterm Birth Alliance before, and very encouragingly, we now have a statement from the Preterm Birth Alliance recommending midwifery continuity of care as a key strategy to prevent preterm birth in Australia. So we need to scale it up. It's not okay to only give it to some women. It's not okay to only give it to the women who can get into the birth centre quickly because they ring the birth centre to book in before they tell their partner they're pregnant. And that does happen. It needs to be available to all women. All women may not take it up, but it needs to be an option for all women. We don't really know what the rate is at the moment. The most recent data suggests it's in the order of 8 to 10%. That's now 3 or 4 year old data. I think it's probably in the order of 15 to 20% of women around Australia, probably more than 15, have access to midwifery continuity of care. It needs to be a lot higher. This study only just came out last week or the week before, and we're now seeing evidence that midwifery continuity of care not only has those other benefits, but also in a systematic review reduces caesarean section without adverse outcomes to mothers and babies. So in a country that has a trickling up caesarean section rate, maybe only 1% a year, but you know, 1% a year keeps going up, this is something we also need to look at. And just to show you, for those of you who love a forest plot, these are the studies. Half of these are Australian. Mine, McLaughlin and Rowley are all the Australian ones. This is overall caesarean section rate, and you can see it favours the midwife-led care model. When midwife-led care is used in that context, it means midwife leading, but within the team. So when women need obstetric care, they get obstetric care. When women need mental health support, they get mental health support. They get hypertension in pregnancy, they see the renal physician. This is not isolated midwifery care over here where we don't get to see anybody else. This is the midwife being the safety net, the moderator, the case manager, supporting women through whomever they need. And the same here is for planned caesarean section. So again, there are only 4 studies looked at planned caesarean section or provided data on planned caesarean section for this review. But again, it's well and truly on the midwifery continuity of care side. So again, another good reason why this needs to be a scaled up intervention. So it's coming. It's not quick enough. And this is my frustration slide. So I'll just share it with you very briefly because we're nearly at lunch. So not all health services think it's important. Not all midwives want to do it. Not all models are sustainable. What we've done in some places is create unsustainable models of care and wondered why they fell over. We've made too few midwives, too many women, too short appointments, too much on call, too much filling up the labour ward when they're not busy. We've just made it not work. We have to unravel the not working and make it doable. It's hard for managers to understand how to do it. It really buggers up people's rosters. It's really hard to unravel the rosters when you You're used to a nice long list of people. You know where everyone is. When you're setting up midwifery continuity of care, you take away a whole bunch of your staff and you don't know where they are. They're on call, they're at home, they might be at the shops, they've taken the kids to the swimming carnival, but they're not on your roster and they're not in your line of sight. And that's a very big shift for most people to do. Understandably, I completely understand that it's hard. And we don't always know where they are. This has been a big shift for organisations like the Australian Nursing and Midwifery Association, our union, around changing the way midwives want to work. So maybe not 8 hours on, 12 hours off, maybe a bit more of a messy looking roster. And finally, when I was doing this in New South Wales some years ago, the industrial body just threw up their arms and said, all right, if you want to do it, do it. But we have to have some constraints around making sure it's safe. Not all doctors think midwives can do it, and this is about making sure that it's an integrated model, it's not an out there model. So of course if the woman needs medical care, of course if the woman needs a consultation and referral, of course we need to interact with all the other workers in the system. This is not independent solo practice. Not everyone trusts or believes the evidence, and I'm getting more and more frustrated on this one, as you've probably gathered. Not all systems are flexible enough. Sometimes we just can't make it work. It's just too hard. My last discussion with one hospital was, we just can't work out how to move the money into a new cost centre, so we're not going to do it. It's too difficult. And, you know, some structures are difficult. Many midwives want to work part-time, and this doesn't always allow them to do that, but there are ways to do it. And not all systems care for the caregivers. And I know this is in many situations, not just for midwives. And blah, blah, blah. I reckon I've heard them all before. You might come up with some new ones. But there are bright spots. I particularly like being able to give this talk here because you're doing great things here. The Centenary Hospital for Women and Children, you've got a beautiful birth centre, fantastic labour ward. I think it's something like 25–30% of women here get midwifery continuity of care. You are probably leading the way across the country. And when you add the Calvary Hospital at Bruce and the ACT home birth program, I can almost get it up to 30%, I think, doing the numbers. So that's really extraordinary. And there are very few big hospitals or states around the country or territories can boast those sorts of numbers. So you're doing great stuff. What about the other 60%? What about the other 70%? Maybe there's a stretch target you could come up with. We're even managing to roll this out in rural Australia. So this was in the paper just yesterday. This is Mount Isa, a small rural town where there's a midwifery continuity of care program. It's catering for 70% of the women in the town, the numbers of midwives. They've just moved the whole service into midwifery continuity of care. They've got some midwives who are still on the postnatal ward for when women are in hospital for any length of time, but essentially the whole service has moved. And there are many rural towns that have done that. Broken Hill is the other sort of famous model that's moved their whole service into midwifery continuity of care with Bachelor of Midwifery graduates and actually servicing the whole town for that model of care. So it is possible. So if it was a pill or a technology, would we do the barriers? Would we say all of that, my long list of irritating barriers? Wouldn't we just kind of make it happen? Wouldn't we just find a way? Surely this is an intervention that we need to do. Surely this will make a difference to maternal health. And is it ethical? Is it ethical to want to do another trial? Absolutely not. Is it ethical to withhold this care to women? Now that we can show all of these benefits, including improving overall maternal health. So I'm going to end with Rodney Sherman's quote again because I really like it and I think it kind of crystallises why maternity care is crucial. It's one part of your hospital or one part of your health system, but it has tentacles that go out, maybe not only for this admission, but it has tentacles that go out for the lifetime of those babies who are being born. So absolutely maternal health matters. And we now need to translate the evidence, not just in one model, in one hospital, occasionally when everything's working well, at scale for all women in all contexts. and particularly for those who are disadvantaged, those who have risk factors, social emotional concerns, who live complicated lives, who are the hardest ones for us to reach. They're the ones we need to most target, because ultimately they're the ones that are most going to benefit. Just do it. Thank you.
Thank you very much, Caroline. Bucket loads of evidence is not something we've heard very much over this meeting. Usually there's a dearth of evidence, so yeah, let's just do it. Do we have some questions for Caroline?
Boone.
Yeah.
Thank you very much. It's very inspiring. How do you define continuity of care? Because there's one aspect where we talk about our continuity model where the midwives look after the women right through pregnancy and then through the birth of the baby as well. But there are also the specialized aspects of care where we have specialized midwives in the clinics that provide the care during the antenatal period. For instance, our fetal medicine clinic has got a midwife dedicated to that. We've started the Preterm Birth Alliance project as well. We now have a midwife dedicated to that as well, who looks after the women who come through that clinic, but does not get herself involved in the birth of the women. So is that considered midwifery continuity of care as well? Because it does improve outcomes as well in those situations.
So I'll just, thank you, very good question, Boone. The data, the trials that we have is across the whole continuum of care. So the 15 odd trials that we have is antenatal, intrapartum, postpartum. So that's the kind of overarching continuity of care definition. But increasingly, we need to get more evidence. So we do have a dearth of evidence about aspects of care, and I think those groups are really important. There's a definition used in the UK at the moment for continuity of care, which is, can the woman name her midwife? Does she have a midwife's name somewhere and a phone number? And I think particularly those antenatal models for high-risk women, maternal fetal women who are attending those services, can they name a midwife? Do they know who they would ring up? And I think we should start to think about that as our definition. So it may not be having to separate it into continuum of care aspects, but when I think about changing stillbirth rates, we've been talking in the Stillbirth Centre for Research Excellence about why is it that if women had somebody to ring that they knew and trusted, they're more likely to ring when their movements are changed, when they're worried. If their movements have changed and they're just going to ring a big scary labour ward and they don't know who they're going to get, they're not going to do that so readily. So I think thinking about do you know your midwife's name is a good definition for me.
And I think there was a question up the back.
Michael.
Michael, then Sally.
No, thanks, Caroline. Just an extension from what Boone's saying. I mean, I understand all your frustrations trying to get continuity from, antenatal, intrapartum, postnatal all in together. But just looking at society now, and I'm talking about doctors and midwives, just how everybody works, do you think that's ever really going to happen across all three areas, just the way people work? Or do you think we're trying too hard to do all that at once, and maybe we should be concentrating more on getting some of those bits in continuity? Because it's just too hard because, I'm old, but all the young people now don't want to work all the time. But no, I'm kidding. But it's society's changing.
Yeah, society's changed. I think it is doable. I think we have created some unsustainable models, as I suggested. And in our enthusiasm to roll it out initially, we put too much pressure on midwives, and it fell over. And so in some instances, it got a bad name, I think, because it was badly designed. So notwithstanding, the world has changed, but I taught midwifery students at UTS on Monday, third year's about to finish. How do you want to work? They want to provide midwifery continuity of care across the spectrum. And they might not all do that for all of their careers. Many of them are young, they want to have their own babies and have flexibility in their lives. But the places where it has worked, the flexibility has made their lives better. And I've talked to midwives who have small children and a supportive life, obviously, and continuity works if they don't have to be, it does work for some people. It's how it's designed. On both of your comments though, any continuity is better than none. So if you can have antenatal continuity, that's a really good start. If you can have postnatal continuity, we know in the conversation before about breastfeeding, women are sick of getting 5 different midwives rock up and give them 5 different bits of advice about how to breastfeed their baby. They want one midwife with one lot of advice that they may or may not take, and that's fine. So postnatal continuity, can't we set up our home visiting centres so that all women receive care from the same midwives? So any continuity is better than none, but health systems, we need to think more creatively about how to make continuity work.
Okay, once.
Tumour. The alternative with this job is shift work. So as a person who has a young family, it's actually more manageable being a continuity midwife than doing the higgledy-piggledy of shift work for me, and I think for others as well.
Okay, we are slightly over time, but I'd like to just have one final question from Sally. Yeah? Thanks, Caroline. Can you use
Hi, Sal.
Sally, can you wait and use...
Thank you so much for that. That was a really, really inspiring presentation. And I would just like you've almost answered it with the previous question, but at the end of the University of Canberra Bachelor of Midwifery, we create about 25 midwives a year, and they are almost all very keen and ready to go into continuity the moment they finish their course. But there is a gap and a reluctance from the service to take them up. So I'm wondering if you can speak, you did a little bit before, but if you could just speak to that a little bit.
Yeah, I mean, I think all new graduates from all services, all programs, whether you're a doctor or a midwife, a physiotherapist, a nurse, you need to be looked after in those first few months, particularly maybe the first year after you finish your training, because being a registered health provider is very different than being a student from whatever discipline you come from. In my observations of places that have taken on new graduate midwifery students is that they generally take about 6 months to get it together around working in a hospital. So 6 months at least, maybe for some less, but shift work's hard to get your head around, coming in at the right time, doing all the things that need to be done, filling in the paperwork, working out how to use the computer, all of that just does take a bit of time to get your feet sorted. And I think it's hard to be a good clinician when you're still trying to work out all that other stuff. So mostly the models I've seen that have worked that give midwives at least 6 months of sort of care and attention, and then put them into a midwifery continuity of care program that's based in the hospital, in the facility. And so then they're always open a door and there's a midwife out in front of them, or pick up the phone and there's a doctor on the phone. They're part of a usual system. You're not sending them out to be an isolated practitioner. So they need some care and love and attention, as all new practitioners do. And then I think they're absolutely perfect. And particularly the young ones, get them early. Get them hooked on continuity of care. They might go and have their babies and then work part-time, but they'll come back to it. So don't waste them if they've got that enthusiasm, but they need a bit of care and attention to begin with.
Okay, thank you very much, Caroline. I'm sure there'll be many more conversations over lunch. Lunch is served immediately outside, but then we are being herded into the sheep pen for some networking and further conversations. But just join with me once again to thank Caroline.
Watching the time.
Can I just ask that we're all back in here for 1:50 for the start of the next session, please?